Good morning. My name is Martin Blazer. I serve as the chair of PACCARB, and I see this meeting is being recorded. It is my great pleasure to welcome you to the 22nd public meeting of PACCARB. This meeting will be focused on issues of communication about antibiotic resistance, especially in the setting of pandemics, and also issues of health equity. The staff of PACCARB has been led by Dr. Joanna Musmar, and for this program, there's been substantial work by Sarah McClellan, Mark Kazmierczak, and Haley Krem. Today and tomorrow, we have a full agenda, and it is also the lead-in to our next in-person public meeting, which will be held in March 23rd and 24th. I'd now like to introduce my co-chair of PACCARB, Professor Michael Apley from Kansas State University, for him to say a few remarks.
Thank you, Dr. Blazer. Welcome, everyone. Appreciate your participation today, especially the members of the public who've tuned in. And with that short thank you to all participating, I'd like to turn it over to Dr. Joanna Musmar, our designated federal officer.
A special thanks to our chairs, and as mentioned, we welcome all of you to our 22nd meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. Again, my name is Joanna Musmar, and I am the designated federal officer for this advisory council. And I'd like to also echo thanks to all of our presenters, attendees, and stakeholders for joining us today, including those of you that have provided public comment and have registered for public comment for later on this afternoon. If you'd like to send in a comment, please email carb@HHS.gov. And those of you that have sent it in, we've shared it with our council members as well. This meeting is a continuation of our work to help inform the Pandemic Preparedness Working Group as they draft their report in response to the Secretary's task that was given to us last year. As you may be aware, Secretary Becerra tasked the council earlier with exploring how the U.S. may leverage national existing pandemic preparedness frameworks to strengthen our defense against antimicrobial resistant pathogens in response to a potential future large-scale disease event. As such, this meeting will explore the challenges regarding communication as it relates to science and AMR during emergencies. The second day will be dedicated to addressing equity and vulnerable populations within response plans. The final report is due to be deliberated and voted on by the full council at our next public meeting, as indicated by Dr. Blazer, on March 23rd and 24th at the Hubert H. Humphrey Building. And we hope that all of you can join us in person or live with the same stream. Just a little bit about the council. This council was initially established via an executive order in 2014 and then in 2019. And we were codified into legislation at that point through the Pandemic and All Hazards Preparedness and Advancing Innovation Act, and is formally reestablished under the statute as of September 2020. The goal of this advisory council is to give the Secretary of Health and Human Services advice, recommendations to improve the programs and policies related to antimicrobial resistance that would contribute to the overall health of our country. To accomplish that mission, the Advisory Council strives to address the issues related to antibiotic resistance through a One Health approach, which is evident in all of our proceedings and products. But before we start, here's a few FACCA rules. First, we are recording this meeting and it'll be available on our website afterwards on hhs.gov/PACCARB. This advisory council is governed by the Federal Advisory Committee Act, or FACCA, where the majority of the work of this advisory council, including information gathering, drafting of reports, development of recommendations, is performed by designated working groups in closed session, who then in turn report to the full council for deliberation and final vote at a public forum. Regarding the conflict of interest rules, all 15 voting members of the council are considered special government employees, or SGEs, and are subject to conflict of interest laws and regulations, as are the 12 regular government employees, or RGEs. Lastly, I would like to thank the amazing PACCARB team, Dr. Mark Kazmierczak, Ms. Sarah McClellan, Ms. Haley Krem, and our fellows, Ms. Chloe Loving and Ms. Zana Francis, and our lovely logistics manager, Ms. Jennifer Adana, for their efforts to support the council and plan for this meeting. Now I'd like to go through a roll call. Please let us know if you're present by stating here. There are a few members that are available and have technical issues, so I'll be voting for them stating here for them by proxy. For our alternate representatives, please identify yourself and provide the name of the principal you are representing today. Starting with our voting members, our chair, Dr. Blazer.
Here.
Dr. Mike Apley.
Here.
Dr. Stephanie Black.
Here.
Dr. Helen Boucher.
Here.
Dr. Virginia Fate.
Here.
Dr. Paula Fedorka-Cray.
Here.
Dr. Christine Janocchio.
Here.
Dr. La Carricker.
Here.
Dr. Elaine Larson.
Here.
Dr. Ramanan Lakshmanarian.
Here.
Mr. Armando Nahum.
Here.
Dr. Payal Patel.
Here.
Dr. Paul Plummer.
Here.
Dr. Julie Simzak.
Here.
And Dr. David White.
Here.
Thank you all for joining us today. I think this is the first time we have every single voting member with us. Moving to our liaison members, Dr. Cully Houston on behalf of the American Association of Extension Veterinarians.
Here.
Great. Dr. Joni Sheftel on behalf of the American Veterinary Medical Association.
Here.
Ms. Emily Wheeler on behalf of Biotechnology Innovation Organization.
Here.
Thank you. Dr. Lisa Mergakis on behalf of the Healthcare Infection Control Practices Advisory Committee. Dr. James Adaskevich for the Minor Crop Farmer Alliance. Dr. Jason Newland for the Pediatric Infectious Diseases Society.
Here.
Thank you. Dr. Libby Dodds-Ashley for the Society of Infectious Disease Pharmacists.
Here.
And lastly, Dr. Tim Jenks for the Wellcome Trust.
Here.
Excellent. Thank you. On to our regular government employees on behalf of USDA representing, or if present, Dr. Jeff Silverstein.
Here.
Thank you. Dr. Sarah Tomlinson.
Here.
Thank you. And Dr. Kiss Robinson Hale.
Here.
Excellent. For DOD, Dr. Paige Waterman. I know that she's with us today. She's having technical issues, so I will count her as here by proxy. For the Department of Health and Human Services, AHRQ, Dr. Melissa Miller.
Here.
Thank you. For the CDC, Mr. Michael Craig.
Here.
Thank you. For CMS, Dr. Sherry Ling.
Jasmine Dunzone for Sherry Ling.
Thank you, Jasmine. For the National Institutes of Health, Dr. Dennis Dixon.
Here.
Thank you. For OGA, Dr. Jose Fernandez. Anyone else on behalf of OGA joining us? Okay. On behalf of ASPR, Dr. Chris Houchins.
Here.
Thank you. For FDA, Dr. Bill Flynn.
Here.
All right. And then lastly, on behalf of EPA, Dr. Jay Garland.
Here.
All right. Just a few more, just quick housekeeping things. Please keep your lines on mute unless you're speaking or asking a question. And I'll now pass it over to our Pandemic Preparedness Working Group co-chairs, Dr. Joni Sheftel and Ramanan Lakshmanarian, to kick us off. Thank you.
Thank you, Jumana. Can I have the slides, please? So the work that is being discussed today is based on a task order from the Secretary of Health and Human Services to critically evaluate pandemic preparedness plans in the context of One Health, and particularly with respect to antimicrobial resistance. There have been previous pandemic preparedness plans put out by the US government, various agencies, but none of them has really taken on the issue of antimicrobial resistance in a specific way. And the purpose of the Pandemic Preparedness Working Group that has now been working for about 8 months on this task as a subset of PACCARB has been working on the issues of how best to leverage existing pandemic preparedness plans to mount a defense against antimicrobial resistant pathogens in response to a potential future large-scale disease event, and also to see how a One Health approach to this task, looking at lessons that have been learned from human, animal, and environmental health domains can be applied to this particular topic. Next slide, please. So the outbreak scenario that we have been working with and was the subject of elaborate discussion during the last PACCARB meeting is a highly transmissible novel reassortant influenza A strain of unknown origin, and which impacts both human and swine populations. There's a significant impact on hospitals being filled to capacity and straining healthcare and other system resources, and also a decline in animal husbandry and swine health because of a depleted workforce. The projected impact of this outbreak would be significant mortality from resistant secondary infections, including pathogens associated with ventilator-associated pneumonia and community-acquired pneumonia. Now, while these are mock scenarios, they're pretty consistent with what we have seen in the past with influenza outbreaks, which have then been followed by secondary bacterial infections, and therefore provide a useful framework for us to think about how best current pandemic preparedness plans can help protect against these scenarios, but also what changes need to be made in order to better respond to antimicrobial resistance threats going forward. Thank you. And with that, I'll hand over to my co-chair, Dr. Joni Shefto.
Joni, you could be on mute. So, Dr. Lakshminarayan, we may have lost Joni. Did you want to just continue?
Sure, please, if we can go to the next slide, please. So the major themes from our discussion in September 2022, when this was subject of an elaborate exercise, was to apply these themes to the current pandemic preparedness plans and look at the development of the pandemic preparedness working group recommendations with respect to three specific areas. One is steady state operations needing investment. This was emphasized by nearly everyone who spoke, who basically made the point that we can't really respond to an emergency if we have not built up the capacity prior to there being an emergency, so that even in routine times, we need to have sufficient capacity to deal with infectious disease threats, both in the human and animal domains. The second point is really about flexibility, the ability to rapidly scale up in response to an emergency event, which doesn't currently exist in all parts of the system. And that investment really needs to be made. So investments are essential now. Investments are not terribly useful when they're made only in response to an outbreak. I think that was amply clear. The third was, of course, that a One Health approach is crucial. It has been a mistake in the past when we deal with animal and human domains separately, even if the pathogen is exactly the same. And close coordination between the two domains was emphasized by speakers at the previous meeting. Next slide, please. So the structure and goals of this public meeting are to identify gaps in pandemic preparedness policies with a strong focus on communications and health equity. Now, communications, as we saw during the context of the COVID-19 pandemic, are all important because what we tell the public, what we tell the healthcare workforce, both of the human domain as well as the folks working in the animal domain, about what is happening and how they need to respond, is critical to getting both trust as well as cooperation across the system. And this issue of trust was really something that has come up multiple times. Now, the structure is, of course, to think about federal communication with states, hospitals, and subject matter experts, how we communicate with the public, how we deal with vulnerable and marginalized populations, and how we address equity and health disparities. Next slide, please. So the logistics are that we will have panel presentations, and then we'll have discussion sessions that are facilitated by moderators, followed by a fairly lengthy open Q&A following, which I hope everyone will participate actively, and all of these will get us towards a final report that will be launched in a couple of months and will be voted on by the entire PACCARB, as Jemana has already indicated. With that, I'll hand it back to the co-chairs. Thank you.
Dr. Blazer?
Yeah, we're a little ahead of schedule. Is our patient here for the patient story?
Hi, yes, I'm here.
Okay, wonderful, wonderful. Well, I'm not going to take any of your time. It's my pleasure to introduce Ms. Tori Kinnaman, who has a story to tell us. And Ms. Kinnaman, we're all going to be listening. Thank you so much.
Wonderful, thank you. And thank you so much for having me to speak here today. It's truly a pleasure and a great opportunity. So my name is Tori Kinnaman, and today I will be sharing with you 3 perspectives on antimicrobial resistance, or AMR. First and most notably, my perspective on AMR as a prior patient with a drug-resistant infection. So in short, I acquired a limb and nearly life-threatening methicillin-resistant Staphylococcus aureus, or MRSA infection from the athletic setting as a freshman in college. And I will share more about that story over the next few slides. But certainly, that experience shaded the lens through which I'll share my second perspective, which is that as a current medical student, both seeing patients with drug-resistant infections on the hospital wards and also how I and the next generation of medical professionals are being trained on antimicrobial resistance and principles of antibiotic stewardship. And third, I'll share a little bit about my experiences as a very, very, very early researcher in the field. Next slide, please. So I grew up doing competitive gymnastics and dreamed of being able to compete at the collegiate level. Was I naturally gifted at the sport? Absolutely not. But I loved it, and I loved the challenges that came with gymnastics, both the physical challenges and the mental challenges. And I worked really, really hard to put myself in a position to be recruited. And so thankfully, I earned a spot on Brown University's Division I gymnastics team, which at the time felt like a dream come true. So in 2014, I was a freshman, and I was doing very well both academically and athletically. I was having a successful gymnastics season and felt the strongest and the most physically fit I had ever been, and really felt invincible, as many college athletes typically do. A few days after the IB championship competition, I had the gradual onset of pain in my left hamstring. I didn't really think much of it. You know, as a gymnast, you always have aches and pains, and you are told to train through them. And so what started out as a dull ache at the beginning of the week worsened with time. I had an x-ray to see if I had an avulsion fracture, worked with my athletic trainer, was resting and icing the area, but continued to have the worsening pain. By the end of the week, I had difficulty walking due to immense pain and the pressure that I felt when I tried to extend my leg. Then over a 24-hour period, I had the onset of fevers and chills and started to feel systemically ill. At that point, my leg was very red and swollen and warm to the touch, and it was clear that this was not just a regular musculoskeletal injury. To make a long story short, I was admitted to the hospital for suspected cellulitis, which is a superficial skin and soft tissue infection. I was also found to have MRSA in my bloodstream, and as such was started on IV antibiotics. However, my condition continued to decline, which led my care team to obtain a series of imaging studies that showed that I had an 18-centimeter abscess deep to my hamstring and an associated MRSA pyomyositis, or muscle infection. Next slide, please. So at that point, it was clear that I needed emergency surgery to gain source control of the infection that was raging through my body. And I distinctly remember the trauma surgery team coming into the room and pulling my parents aside to speak with them. And then my parents coming back into the room with very concerned looks on their faces. And there had been this question that was on my mind that I was too afraid to ask at that point, but I needed an answer. And so I asked the surgeons if they were going to have to amputate my leg, and they couldn't answer me. Ultimately, I had 8 surgeries over a 2-week period of time to debride the infection from my leg and spent over a month in the hospital, including some time in the ICU after one of the surgeries did not go as planned. And to say the least, it was jarring. As a 19-year-old collegiate athlete who had won a championship competition with her team just a week before, to have to go to sleep for multiple surgeries, not knowing if I would wake up with both my legs. That was terrifying for me. And my poor mom, she slept in the hospital chair every night while I was in the hospital. And I think the 3rd surgery was the worst one, when the surgeons were really struggling to gain source control. The infection had spread up and down my leg to an extent that they weren't expecting. And she told me afterwards that she'll never forget the conversation that they had after what was supposed to be a relatively short surgery turned into a few hours. And the surgeons greeted her in the waiting room, and they told her, they said, look, first we focus on saving the life, and then we save the limb. So the incision may not be pretty, but your daughter will be fine in the end. And as you can see here, the incision isn't necessarily pretty. Now I have a 2-foot-long scar on the back of my leg. But that scar reminds me every single day of my confrontation with antimicrobial resistance. And honestly, reminds me how lucky I am to have been in a place with high-level surgical care and antibiotics to treat my infection. And that brings up two important points. The first being the importance of having antibiotics available. For instance, I was initially treated with vancomycin, which is the drug used to treat MRSA infections. However, it can be toxic to your kidneys. And at one point, my kidney function actually started declining precipitously. Thankfully, there was another antibiotic available, daptomycin, that I could be switched to treat my infection. I reflect quite frequently about how my outcome may have been very different if we didn't have that option available, and I was left with the choice of having a raging infection or kidney failure. And so having antibiotics in the pipeline, both because pathogens are developing resistance at fast rates, and also because some patients do not tolerate the toxic effects of certain antibiotics, is critical. The second point being access to care. I was at a level 1 trauma center with great surgeons, great infectious diseases doctors, et cetera, et cetera. And during my hospitalization, perhaps offhandedly at the time, someone told me, they said, wow, you're lucky that you're not in a third world country with this infection. Otherwise, you probably wouldn't be here. And while that's true, I don't think that statement is restricted in its applicability to third world countries. In this country, diagnosing these infections sooner rather than later certainly affects outcomes. So people in areas with poor access to medical care may suffer, or people who don't have a suspicion that their red swollen leg is infected, they don't have a hospital nearby or someone encouraging them to seek care, could also have poor outcomes. Furthermore, if I had any comorbidities, such as being immunocompromised or having diabetes, wasn't a young, healthy 19-year-old, so on and so forth, my outcome likely would have been grave. And the second point is something that has been reiterated to me time and time again as a medical student on the hospital wards. Next slide, please. Certainly, I feel that being a patient on the receiving side of medicine has enabled me to empathize with patients hospitalized with drug-resistant infections. We're all asking ourselves the same questions, some of which are shown here. Why did this happen to me? How did I get this infection? How do I prevent it from happening again? Can the doctors treat this? Will the infection come back? How do I know that the infection is gone? Personally, I can tell you that as much as I wanted to be discharged from the hospital after spending over a month there, I was also scared to leave. I was scared before the last surgery and asked the surgeons time and time again, how do you know that the infection is gone? Being sick with an infection is different than other illnesses because it truly feels like something else, something so far outside of your control is taking over your body, and you honestly feel rather helpless against it. It's physically, but also psychologically taxing. And I remember asking my doctors all of these questions, especially the second and the third questions. And they told me, MRSA, it's everywhere, especially in the athletic setting and even in the healthcare setting. You just got really unlucky. And so that fear of reinfection, the fear of getting sick again, stuck with me for a while. Not to mention the air of invincibility that I once had was certainly swept away with certain aspects of my identity when, in an instant, I became a patient with an MRSA infection in room 305, and not any of the other pieces of my identity that I held so close to my heart at the time. Next slide, please. I think overall it's important to share my story because it conveys that antimicrobial resistance really is a threat to all of us. I think many of us have had the luxury of thinking that AMR is not something we may need to be concerned about because we may only associate it with the hospital setting or people who are immunocompromised or have other comorbidities. But that's not something that we can afford to do anymore. As rates of resistance rise and as these pathogens become more virulent, AMR is becoming more and more of a community threat. That said, and without a doubt, AMR certainly burdens some populations more than others, such as the immunocompromised and those who are vulnerable and marginalized. The picture on the bottom refers to an immunocompromised patient and her mother. So pictured here is Mallory Smith and her mom, Diane Schaefer-Smith, who is an amazing advocate on behalf of her late daughter, Mallory, who unfortunately passed away at the age of 25 from a drug-resistant lung infection that she had in the setting of cystic fibrosis. And I've had the absolute privilege of working with Diane on a few panels related to patient advocacy and AMR. And so I encourage you to look at some of Diane's work and Mallory's memoir, Salt in My Soul, in which she documents what it was like to live with cystic fibrosis and constantly battle these drug-resistant infections time and time again. The graphic picture here is from an article in Nature Medicine and portrays various factors that could potentially contribute to racial and ethnic inequalities in antimicrobial resistance-related morbidity and mortality. And I touched a bit earlier on how being able to access medical care and how underlying comorbidities may place you at additional risk for certain types of infections or poor outcomes from those infections. But you can see some additional reasons here. However, the authors of that article do note that research and data collection related to the topic is scarce, and certainly more work is needed in this space. Another article, I have the citation here at the bottom. It's by Ruffin et al., who's one of my mentors. And Dr. Ruffin recently published this, and I'd encourage you to take a look at it. It's an article in Clinical Infectious Diseases that examines how the risk factors differ between Black and white patients who end up having Staph aureus bacteremia. Next slide, please. And one last point I'll make about antibiotics and why it's so important to communicate the threat of AMR clearly with the public is that antibiotics are the safety net of modern medicine. You know, we treat cancer patients for their cancer, but we need antibiotics to treat the very complex infections that they acquire as well. We can perform these really incredible and cutting-edge surgeries, but patients are on antibiotics intraoperatively during those infections during those surgeries to cover for potential infections. You know, we can stabilize a patient from a horrific car crash, knowing we can treat an infection that arises from, say, their open fracture. And I think, you know, in sharing my story with peers, with other athletes, with patients, colleagues, researchers, it's become clear to me that most people know someone who has been affected by a drug-resistant infection. And when you experience it personally, or you see how drastically it affects your own life or those of whom you love, it's a game changer. And that's what gives me the fuel to keep sharing my story and to raise awareness and advocate for and educate patients on a regular basis. Next slide. That said, my confrontation with MRSA directly influenced my trajectory into medicine and sparked my interest in infectious disease, microbiology, public health, antimicrobial resistance relatively early on in my training. But I thought it might be of interest to you all to learn how medical students are being educated on the topic of AMR. Because I think if we really want to start creating a change regarding how antibiotics are used and how stewardship is emphasized, it really starts with educating the next generation of medical professionals. And so here I've outlined briefly how I've been educated on it at Duke University School of Medicine, which is what I'll be speaking to. And I talked with my course director, he's an infectious diseases doctor at Duke, Dr. Andrew Alspaugh, about the curriculum's inception. And so essentially in 2013, 4 schools, to include Duke, Stanford, Michigan, and UCSF, got together to create a core curriculum for microbiology and immunology training for medical students. And, you know, Dr. Alspaugh told me that unanimously, everybody agreed that there needed to be an emphasis on antimicrobial resistance and antimicrobial stewardship, you know, training students to think about how do we use antibiotics appropriately and intentionally, and understanding why you would use one antibiotic over another in a certain clinical scenario. And the curriculum does so by educating us on the microbial complexity of anatomic sites, you know, helping us to develop clinical reasoning skills by providing patient vignettes in which we walk through what's happening, why it's happening, why we are treating them in a certain way, and also introduces us to the potential consequences of inappropriate antibiotic use. Lastly, Dr. Alspaugh made a great point in that, in his mind, the most important teaching is that which happens in the moment. And I can honestly say that, you know, again, at Duke, I was blessed with a number of wonderful attendings on my medicine rotations who took the time during hospital rounds to educate us about infection prevention and control practices within the hospital and antimicrobial stewardship at large. Next slide, please. I won't get much into the details of the research that I'm doing now, but I think in essence, as a young person in the field and as an early researcher, what's been reassuring to me is that there are so many amazing institutions and organizations and opportunities for collaboration from a research standpoint within the field. And I think that's what we need moving forward. There are so many smart minds and passionate people, some of whom I know on this call. Nice to see you, Dr. Boucher, who are working on AMR. And so uniting all of those efforts is critical. And I've been very grateful for the mentors I found at Duke, who've given me a springboard to really dive into research on various topics such as staph infections and infection prevention and control protocols. I'm also currently an ORISE fellow at the FDA, learning about how we conduct trials for antimicrobials and how we can potentially innovate them to really elevate the patient voice in these trials. And another group that I've been privileged to be a part of and that I want to highlight is the Antibacterial Resistance Leadership Group, which just continues to amaze me with the scope and breadth of their work and the opportunities that they provide in clinical trials, in basic science, in DEI, and in educating the public as well. Next slide, please. So that essentially concludes my presentation, and I hope that it's clear that as a patient with a drug-resistant infection, how passionate I am about moving this work forward and changing the trajectory of AMR. So happy to take any questions if there are any at this time. And again, thank you so much for your attention and for inviting me to be here.
Ms. Kinnaman, thank you so much for your oration. Not only are you a medical student, but you're a great educator as well. And I think you have educated us so well and told a very compelling story. I'm particularly interested because I was involved in the training of Dr. Andy Alsbaugh. So now we kind of
really
now we move it out another generation. And I think it's very important that your generation be the vanguard. Your generation is the first generation of students who will become health practitioners who are faced with this issue that hasn't really been there for generations now. We've had 4 or 5 generations where we've lived under that antibiotic umbrella, and now, as you point out, it is eroding, and we have to prepare for that. People in your generation are going to be at the vanguard to prepare for making new antibiotics, but also using the ones we have wisely, and that the safeguarding of the use, when not to use antibiotics, when to use as little as possible. These are important lessons for generations that have not seen it as a limiting factor. So I just want to thank you and congratulate you. I'm glad that this is recorded because your address is quite meaningful. Thank you.
Thank you so much for those kind words.
Jason, go ahead.
Future Dr. Kinnaman, as Dr. Blazer said, you are absolutely fantastic and amazing. And I want to be the first to say that I hope you're going to be an infectious disease doctor. And as a pediatric infectious disease doctor, I see you've got a lot of opportunity working with wonderful adult ID doctors. I'd like to put a plug that you need to go into pediatric infectious diseases. We would love to have wonderful, athletic, intelligent, wonderful presenters join our wonderful field. It is obviously overlaps with the adults. You are very impressive. You will make our field better. You will make the world better. I guess my question, because I just want to keep hearing you speak, what is your feeling regarding your classmates in regards to this topic? You've mentioned the this great educational effort among 4 medical schools. I'm just curious, what does it resonate to them as much as you? And obviously you have personal experience, but I'm just curious in your own day-to-day work with your other colleagues.
That's a great question. And I could honestly say, if I had not had the experience that I had with MRSA, I don't think infectious disease would have been on my radar, honestly. And I think, my classmates, they certainly listen and they're engaged, but until you actually experience it, I think it's hard for you to realize how it could actually affect you. As I said, I've been able to do a lot of work with the cystic fibrosis, patient panel. And I think a lot of the times, it's easy for those of us who don't have any other medical comorbidities to kind of put ourselves at an arm's length from people who we think are more susceptible to these infections. And so, I would never wish anybody a drug-resistant infection, for them to have to experience it. But I think one thing that does make them a little bit more aware of these infections is once you have your first, as a student, once you treat your first patient with a drug-resistant infection, and you kind of see the gravity at which we are at with antibiotics and how they are in the pipeline, it becomes a little bit more real. But because of that, I do make it a point to share my experience with my classmates. And I think many people are surprised that I had the experience that I did. And I know even within collegiate athletics, because I did a lot of education of college athletes, because in that space, having to cut or scrape, that's like a staple of glory. It's like rub some dirt in it and move on. I don't need a Band-Aid. And I stopped people in the training room, showed them my scar, and was like, you're putting yourself at unnecessary risk by doing X, Y, and Z. This is a group effort, and I think it's very easy to think it can't happen to you until it does, which, again, as uncomfortable as it was for me at first to share my story with others, I think that's why I think it's very important to, hopefully have this storytelling component that helps everybody understand how it could really be any of us, though, again, certain populations certainly experience the burden of it more so than others.
Thank you, Dr. Craig.
Thank you, Joanna. Tori, I'm interested to know, during your educational experience, have you had the opportunity to interact with veterinarians or veterinary education in any way? And I have a follow-up to that, depending upon your answer.
So, not extensively. I will say the one area in which it overlaps, and I was actually talking to an orthopedic oncology surgeon at Duke, and he was a veterinarian previously and then went into orthopedic oncology and now has a very keen interest in musculoskeletal infections. And so I know that some of that roots kind of in his veterinary medicine background, but I've not talked extensively with him about that, nor do I have much exposure to veterinary medicine. Though we did have, and I know One Health, we had one lecture, unfortunately, on One Health, but don't get much other training or exposure to it otherwise.
And what do you think can be done to rectify that situation so that you do have more exposure and that all medical students have more exposure to infectious diseases as a whole and resistant bacteria?
And actually, this is a point I forgot to make in my talk, and something I talked with Dr. Alva about. So unfortunately, medical students are largely driven by, of course, patient care, but what do you need to know for the board exam? And Dr. Oswald is saying that there have been more questions included on recent board exams about antimicrobial resistance, principles of stewardship, because if it's on the board exam, medical students will study it relentlessly to the end to make sure they have all the details down. So I think, pushing that more infectious disease topics, so on and so forth, are included in those national exams, thus will have schools incorporate it into their curriculum, because I do think it is something that we should be exposed to. So we can think more about it, as well as promoting research opportunities. Again, once I started sharing my personal story with people, I feel like a lot of these opportunities were just dropped into my lap, some of which I had to pinch myself that they were actually offering me that position. But when you start making these research opportunities available, start having people speak about their research and, its effects on society at large, I think that is very appealing to medical students. And so I guess in short, putting this as part of their curriculum and then just continuing to provide students with opportunities would be a good start.
Thank you, Tori.
Very much.
So just the next three questions, ending with Dr. Helen Boucher. Dr. Prabha Fernandez, on behalf of the National Biodefense Science Board, on our Pandemic Preparedness Working Group. Dr. Fernandez?
Thank you. Tori, I enjoyed your presentation a lot, and I want to get some recommendations from you as to how we can get more young people such as yourselves into infectious disease. What is that we can do to help get people into infectious disease? What do you think down in the weeds? You're there. What will help your colleagues to get into infectious diseases?
That's a challenging question. Actually, something else I talked with Dr. Alspa about in regards to the ID fellowship and how many spots kind of went unmatched this year. And unfortunately, I think the reimbursement model, when people are hundreds of thousands of dollars in debt from medical school, when they have that on the horizon, something where they're not going to get that payback, that unfortunately comes into play for many people. I will say, thankfully for me, I have a military scholarship for medical school, actually. So money's not an object. And again, very fortunate to be able to say that. And I look forward to a career in military medicine, but then also the personal interest drives me as well. I think having educators like Dr. Andrew Alsbaugh, which I wish you all had the pleasure of meeting him, and seeing him interact with patients took me kind of over the edge for my interest in infectious disease and how humanistic really the specialty is. And also, I think promoting the vast amount of opportunities within infectious disease for patient care, research, industry, regulatory science, it's really endless, and things that I did not know about at all until I started kind of getting more and more immersed in this group of infectious disease doctors that I'm blessed to be mentored by. But that's a really challenging question. I wish I had a better answer.
Dr. Simzak?
Yes, Tori, I just really wanted to thank you for an incredible presentation, and particularly to highlight for our discussion tomorrow how much I appreciated you bringing in the equity lens to your discussion. And in particular, I loved that figure from the Nat and Polly Nature Medicine piece, which I think really demonstrates one health equity, and it frames what we're going to be talking about tomorrow. So I don't really have a question, but I just really want to say thank you and highlight for the rest of my colleagues, I think, the importance of thinking about this in a sort of socio-structural way. So thank you again.
Thank you, Julie. Dr. Boucher?
Great, thanks very much. Two quick comments. So I'll just say Dr. Nanampally and Dr. Daron were my former trainees and worked in CMAR at Tufts. I'm very proud of their work. And Tori, couldn't be more thrilled for all that you've accomplished, and thank you for giving of your time to tell your story. I wanted to come back to the education piece and just add, the board exams matter, but the ultimate arbiter is the LCME, the accreditors of medical schools. They dictate what we can put in the curriculum, and the curriculum is very crowded. So I would hope that in our role as the PACCARB, we could try to elevate this, because it's places like the government and groups like ours that can sound a voice that's loud enough, right? It's been done for climate science. You might have seen that medical schools are now covering climate change as part of our curriculum, but AMR certainly has risen to that level, and I hope we'll use our influence that way if we can. So thanks again.
I wonder if I can make one last comment, and that is, again, to thank you so much, Tori, for terrific discussion. I want to mention one discordant note, and that is something that you mentioned, which is that medical students study topics because they're on the test. And I think that we as educators have failed if that's the criterion. And I would really ask you and your generation to go beyond that, to study things because they're important, because they're intrinsically important, not because they're on the test.
I would definitely agree with that. I think I'm perhaps a bit jaded because I just finished studying for step 1 and step 2. So the board exams were still very high on my mind, but you're right. And honestly, I think with some of the pushes in medical education where courses are pass-fail now, it gives you more time to really focus on preparing for your patients, thinking about what matters to the patient and why it matters. And so, I view that as personal opinion, view that as a positive. But again, thank you all for your time and your comments.
Thank you, Tori, for joining us today. This has been one of our best patient stories, so we appreciate you setting the stage and tying everything in together so nicely. It's been great. We appreciate it. So now that we're at time, Dr. Blazer, we're going to continue on to our panel, yeah?
Perfect. Thank you. Thank you for the great introduction, Tori.
All right, Dr. Virginia Fate, you are moderating this session, so please take it away.
Good morning, everyone. This has come up, and it always comes up when we talk about antibiotic resistance, and that is the challenge of communicating the science, the patients, the dealing with the public, media, and so on. And so this panel is designed to address some of those issues, particularly related to federal communication. And so we have 4 panelists: Katie Abrams from Colorado State, Arjun Srinivasan from the CDC, Benjamin Chan from the New Hampshire Public Health Department, and Russ Daly from South Dakota State University. with that, let's go ahead and get started with the first panelist, Katie Abrams.
Okay, good morning. I'm grateful for this opportunity to speak with you among several, oh, there we go. Perfect. Looks like the video is working now. As I was saying, I'm really grateful for the opportunity to speak with you today among several excellent panelists about developing processes and products for effective science communication. And I'm going to talk today specifically about that aspect within the agricultural sector, the livestock sector, as it relates to antimicrobial resistance. I am an associate professor with the Center for Science Communication and the Department of Journalism and Media Communication at Colorado State University, and I specialize in strategic, agricultural, and natural resources. Next slide, please. So to address the bottom line first, effective science communication about antimicrobial use, or AMU and AMR, is not only contingent upon what you see at the top of this triangle here, developing media and information designed for attention and quick usability, but also, and more foundationally, on establishing and cultivating high quality relationships and shared narratives or key messages about the crisis among agricultural stakeholders. And another problem to address, especially in AMU monitoring, is survey fatigue, because our research showed that it was connected in part to communication. And all of these are connected and influence one another, but today I'm going to focus my presentation on the communication aspects, which is why you see the survey fatigue grayed out here on the slide. However, I'm happy to, of course, answer any questions among the council on survey fatigue among agricultural producers. In a crisis situation, such as the one the council is considering, a laudable aim is to conduct research quickly, resolve uncertainties, and encourage best practices for AMU among livestock producers, their workers, and veterinarians. And as I said, integral to what I'm talking about today is not just the communication of the science itself, but also communication and stakeholder relationship components necessary as a part of AMU and other animal health research being conducted. Next slide. I'll be sharing some key findings from research I led in collaboration with the National Animal Health Monitoring System Unit and USDA APHIS. This was done at the time when they were launching their cattle and swine AMU studies. And this context provides a useful case study through which to consider AMR communication within the animal health sector. And what we did is we conducted in-depth interviews with representatives from national livestock industry groups, university extension specialists in animal health, journalists for major agricultural media outlets, and national advocacy groups with varying views on AMU and animal agriculture. And all interviewees were responsible for some aspect of communication on behalf of their organization. And the practical purpose of our study was to formulate recommendations to improve communication and relations among APHIS and its stakeholders. And I'll begin with a few relatively straightforward findings and recommendations that emerged. Next slide. In general, for more immediate or likely use of animal health and AMU research, the first and foremost commonly mentioned change that interviewees said that they would like to see is greater variety in how this information is communicated. Related to this theme, we saw that our stakeholders were pointing out problems that they have finding information on USDA websites, is where they primarily focused, of course, and that Google searches often do not lead them to USDA or other entities that they would consider high quality. Therefore, a review of search engine optimization as well as usability and accessibilities for these websites is likely overdue when even experts and industry leaders report having trouble finding them. In a crisis, finding credible information quickly and easy is crucial, and the time to ensure that digital communication about AMU is easily discoverable and usable is, of course, before a crisis. And also, when listening to the kinds of variety desired by stakeholders about AMU, what we heard was a call for a more complete communication package that includes media releases customized for different types of entities. So media entities that might focus on the general public, those more customized for animal health, and of course, those focused on specific agricultural commodities. They also wanted to see, surprisingly, email newsletters that people can subscribe to, or some way in which they might receive push notifications of reports on AMU. They want shorter and more visual reports of key findings using infographics, as well as quick accessibility of presentation slides with visuals and summaries of important information. And with a lot of these requests for variety, we also heard mentions to communicate risk and data visually throughout this. And when it comes to risk communication, many studies support that when visual communication is done well, you generate awareness, spread information more quickly, enhance recall, and enhance behavior change. And while such media is certainly beneficial to best manage risk and navigate crises, continuous interaction with stakeholders is also key. This was echoed in our findings when stakeholders highlighted the importance of interpersonal communication and suggested USDA, APHIS, and NOM staff should attend webinars and presentations at relevant industry conferences or educational events hosted by agribusiness companies, saying that such tactics would not only increase reach, but reach a wider array of stakeholders like advocacy organizations, journalists, and extension agents. And our findings suggest that they would also increase the likelihood of AMU information would be used, shared, and interpreted into best practices and policy if such interpersonal communication were to occur with greater frequency. And because AMU data is typically not interpreted or formulated into practical recommendations, at least that's something that NOMS reported to me they don't do, the research needs to reach those knowledge brokers in a meaningful way in order to have the potential to create impact. What was notable throughout this line of questioning was that participants revealed how AMU research and studies would need to potentially change before they would consider using it or sharing it with others. Next slide. Ultimately, except for the journalists we interviewed, all interviewees expressed a desire to be more involved in the research process for AMU and called for more relationship building across various stakeholders for AMR in the animal agriculture sector. When it came to extension agents, our interviewees representing extension said that they view USDA and APHIS as a trustworthy and credible source of information, but feel that extension is overlooked as a stakeholder for AMU and AMR communication. They believe they have a great deal to offer to help communicate and build those critical communication networks. They described how extension could act as an information intermediary, much like industry organizations do in disseminating important research information. These extension interviewees echoed industry group recommendations on the importance of making state-specific relationships. They suggested extension personnel be a point of contact to such ends, which of course also provides another means of potentially enhancing interpersonal communication at that state and local level. Gaining trust and credibility with local, county, and state experts could of course help federal agencies, as extension groups can help foster relationships and positive experiences and perceptions among producers. Next slide. As we interpreted our interview data in which participants discussed the strengths and weaknesses of relationship, we considered prominent scholars' theoretical work in this area on the dimensions of relationship quality. There's control mutuality, which is about the rightful power to influence one another, trust, satisfaction, commitment, an exchange relationship, which is about benefiting one another, and communal relationship, which is about each stakeholder's concern for the other's welfare. And although you look at this and it looks like trust appears as a mere singular component of relationship quality, arguably each of these dimensions interplay with one another to shape trust. And other scholars in science communication have shown that perceived fairness of a process or its outcome is closely related to trust in science communication specifically, and fairness is directly related to relationship quality. Next slide. One relationship we discovered needing bolstering through our research, particularly around AMR, is relations with the cattle industry. Participants with the cattle industry described their relationships with the federal government as fraught with frustration. And this was, of course, specifically related to AMU studies in particular, and the perception that there was not enough time or due diligence for conversations with industry representatives. Interviewees, though, described that a key influence on them is the cattle producers themselves, of course, who they described as strongly valuing privacy and sensitive to any talk or act that resembles government intrusion on their cattle business. And these views, however, were not prevalent or brought forward among those connected with the swine industry. Next slide. So to briefly recap and dive into some more implications of this work, when it comes to science communication for AMU and AMR, more effective communication and likely use of such information is contingent upon diversifying data communication tools and strategies. This can be done through offering push notifications of some sort, increased mini reporting with varied highlights, more visuals, and other media. And not to be overlooked is increasing interpersonal or small group communication with stakeholders, particularly in person. And I do want to point out that these data were collected before COVID-19 hit. So we often hear that today of like, oh yes, we're excited to get back in person and we want everything back in person. But this was not an overreaction to the COVID-19 pandemic. So second, ensuring that federal government agencies maintain good relations with extension agents as well as journalists. Those people in those roles play important roles as knowledge brokers. And knowledge brokers in a crisis and risk communication context can help slow or prevent miscommunication and bolster dissemination of recommended actions for producers in a pandemic. Next slide. And when it comes to enhancing relationship quality, there needs to be targeted efforts to improve relationship quality with the cattle industry around AMR. Some of these problems brought forward in our interviews can be repaired through highlighting the give and take in the development and deployment of AMU monitoring on farms, conveying and expressing concern for the industry's welfare, and of course, reigniting and demonstrating commitment to the relationship. Next slide. As for other ways to enhance relationship quality after AMU data collection or even after a crisis situation, key messages and communication would bolster relationship quality if they focus on identifying ways in which their stakeholders did influence AMR and AMU federal data collection, as well as reiterate the why of the study in terms of concern over the industry's welfare or whatever stakeholder group they're representing, their welfare. Number two, expressing gratitude. It's simple. You hear those things. We could always do better by expressing gratitude for one another. It does go a long way. Expressing gratitude for contributions and identifying commitments made, specific commitments made, and future commitment to the relationships. You also want to highlight the benefits given of their insight as well as the benefits that they received. And finally, reminding them of the boundaries of influence that are necessary in order to ensure that studies are credible and robust and are biased to attacks by demonstrating inclusiveness and the balancing the viewpoints. And though in continuing our work with USDA-APHIS, our team put some of these recommendations into practice, as best as we could within the existing digital media structure for NOMS, we have not been able to evaluate these theoretically effective recommendations. Next slide. So I have for you briefly another study led by Dr. Tim Selnow out of the University of Central Florida, in which they examined what they call a success story of the swine industry's response to PEDV outbreak. Their study revealed that communication efforts made by swine industry leaders successfully shifted the PEDV story from that of competing narratives to a dominant narrative that helped the industry, that helped resolve the crisis efficiently. And this success they attributed in part to the effective use of all available industry resources for both conducting research at what was described at blazing speeds and sharing information rapidly through pre-established communication networks and widely read resources. And much of what our study offers in terms of recommendations were exactly the factors that helped the industry respond to this crisis. So similar to what our data advise, these researchers illustrate the value of encouraging industry cohesiveness, developing networking and rapid research capacity, and effectively communicating and disseminating science and recommended actions, which our study provides some more details about how you go about doing that. Next slide. So in conclusion, the foundation for effective science communication for AMU is the cultivation of networks with strong relationships that help develop shared narratives important to necessary actions within the ag industry to address an animal health crisis. In addition, when communicating data that veterinarians and producers need to act quickly on, it needs to be designed with people's attention and usability at the forefront. And these studies highlight some of the ways that can be done. While these findings are certainly valuable, future investments in science communication research in this sector would allow us to better understand more about bolstering relationship quality, particularly when it comes to the cattle industry, and collaboration, as well as, very importantly, plan communication and behavior change techniques to improve biosecurity and AMU. Next slide. That's what I have for you. Thank you for listening. I look forward to hearing how the other speakers on the panel will further add to the considerations the Council must make to enhance communication effectiveness of antimicrobial resistance.
Thank you, Dr. Abrams. We're going to go ahead and go right into the next presentation. Dr. Arjun Srinivasan from the CDC, take it away.
Fantastic. Can you confirm that you can hear me okay?
Yep.
Great. So it's such a pleasure. It's always a pleasure to be able to share information on behalf of the CDC's Division of Healthcare Quality Promotion with the PACCARB. So thank you so much for having me back. Next slide. So I'm going to talk a little bit about how CDC uses science to guide practice. I'm going to focus on the practices for providers and health departments, but it is important to know that CDC obviously makes recommendations for pretty much every group that's out there, right? We have recommendations for the general public, and we also make recommendations for healthcare providers and facility administrators in every healthcare setting that's out there. And we also work to guide practices in health departments as well as clinical and public health laboratories. So we have to consider, a full spectrum of audiences when we think about the ways that we can use science to guide practice. Obviously, in this talk, I'm going to focus on these second two domains, focusing on guiding the practices of healthcare providers. Next slide, please. We do this in kind of two broad domains. I mean, we have two mechanisms for ways that we can make recommendations to guide practice. And the first is what we call guidance, right? So in guidance, these are suggested practices that are based on available data. Some might be randomized trials, but they don't have to be. And they can also include expert opinion and experiences. So there may not be as much data, but we feel that this is a place where we need to be able to say something, to give people some idea of what we think the best practice is in an area based on what we know now. Guidance is generally developed internally by CDC staff, and you will sometimes see the term interim guidance get put in front of our guidance documents, and it refers to the fact that guidance is often updated as information becomes more available. It may change. Some guidance changes more frequently than others, and it may be time limited just for an emergency response. In contrast, the other domain of ways that we make recommendations to guide practice are what we call guidelines. And these are quite a bit more formal. These are generally evidence-based practice recommendations that are based on systematic literature reviews, and generally they use that GRADE framework, the grading of recommendations, assessment, development, and evaluations, which has become kind of the foundation of evidence-based guidelines. These are usually developed in collaboration with external experts and often, in fact, almost always include opportunities for public comment. So this is a very formalized process, generally led by external experts making these recommendations that CDC then codifies into a guideline document, usually through under the auspices of a federal advisory committee. Next slide. So just some examples of what each of these look like. And probably more of you all are probably more familiar with this than you ever wanted to be, right? So this is an example of guidance, and this is specifically interim guidance. This is the COVID guidance for infection prevention and control in healthcare personnel, right? So the COVID infection prevention guidance, this was guidance that was updated many times, sometimes multiple times per year since the start of the pandemic. And as new information came in, this guidance document was updated to incorporate the latest practice. And here, this was a great example of not having any randomized control trials initially. We were working off of best practices, what we learned from other diseases, what we knew about initial experiences with COVID. These interim guidance documents, particularly during an emergency response, are generally archived when that response is over. So for example, the guidance for interim guidance documents for SARS, for MERS, those are now all archived. They're not active on the CDC website anymore. Next slide. We also have guidance documents, I think much more germane to this discussion. We do have guidance documents that are focused on best practices for preventing the spread of multi-drug resistant organisms. And this is a guidance document that, as you can see here, has been around for quite some time, for more than a decade now in some form. In 2012, we issued an initial guidance document on controlling the spread of CRE based on experiences here in this country and in others, primarily Israel, shared a lot of great experience with us. And then over the years, we have revised that guidance document, initially focused still on CRE. And then in 2017, we expanded it to include a broader set of multi-drug resistant organisms. And then in 2019, we again revised that guidance, and it's now called the containment guidance, right? It focuses on the ways that we can contain the spread of multi-drug resistant organisms. These are guidance documents developed internally by CDC staff. And you can see in 2019, we did affix the term interim just to help people know that, this is guidance that is likely to be updated over time as new information becomes available. Next slide. Contrast that to the guideline process. We do have a guideline process for infection prevention and control guidelines. We have a federal advisory committee, the Healthcare Infection Control Practices Advisory Committee, and the current chair of that committee, Lisa Marigakis, is one of the liaison members of the PACCARB. The guidelines, this is a rigorous process, and it's a lengthy process. It is supported by systematic reviews of relevant evidence, and there are a number of rules that are written into the ways that we must put these guidelines together. The first is that there is a very strict process, just as there is for PACCARB, for ways that we disclose and manage conflicts of interest. In general, we try to do this in 18 to 24 months, but sometimes it takes longer. That is a goal. Stakeholders are involved throughout the process. There are a number of societies that are non-voting members of HHCP, and these groups do get to weigh in throughout the guideline development process. It's a transparent process. The meetings are public. The deliberations must be open to the public, and there have to be multiple opportunities for public comment so that we can solicit those comments from the public, from the practicing community on what they think about the guidelines that are being developed. Because this rigorous process and the level of evidence that goes into these guidelines, these are often considered standards of care. The CDC guidelines are referenced in a number of regulatory and accreditation standards from groups like the Center for Medicare and Medicaid Services Conditions of Participation, as well as numerous Joint Commission standards and DNV accreditation standards. Next slide, please. Well, because of the differences in these two processes, there are some flexibilities that we have when we are developing guidance that we don't have when we're looking at guidelines. And this is a great example of that, right? So the question oftentimes comes up, well, when can we stop contact precautions, right? If we've put someone on contact precautions for a multi-drug resistant organism, when is it okay to stop putting that person on contact precautions? And there is, I think, a general sense, there is some general guidance from the field. And so you will see in our containment guidance document that we do include information that comes from what is kind of considered the best practice right now based on expert opinion and some small published studies. So you see here, failure to identify the organism from at least 2 consecutive sets of screening cultures are the minimum criteria that should be met. So we try to provide at least a best practice recommendation there. Contrast that to what we can say in the MDRO guideline. Here it says, no recommendation can be made. And so here, when you're dealing with a guideline, there has to be a level of evidence that's met in order to make a recommendation. And we simply don't have that level of evidence when it comes to discontinuing contact precautions. So it's a different recommendation that has to be made. It's a no recommendation versus at least a suggestion of best practice that's in the guidance document. Next slide. The role of HHCPAC has been expanding. The field of healthcare epidemiology and stewardship, I think, have often called for a body to weigh in on some topics. Even when there's not a strong evidence base, they have really encouraged HHCPAC to say, well, could you at least weigh in on what you think is a guiding practice for the field? Can you make some suggestions here? And HHCPAC has started to play that role. They do view that as an important role that they can play, at least in making statements about where they would like to see the field moving, especially when it comes to other groups that might be developing treatment guidelines. And this is one example of that. In 2016, HHCPAC in their deliberations felt, we need to weigh in and encourage people to think about ways to better support efforts to address antimicrobial resistance and antibiotic use in their treatment guidelines. And so they developed this statement, and this is just one line from it, where it says professional societies and guideline developers should incorporate the principles of diagnostic testing and treatment directly into recommendations included in their treatment guidelines. So this is not a guideline from HHCPAC per se, but it is a statement on where HHCPAC thinks that the guideline development should go, whether it's being done by us or by other groups. Next slide. CDC also does develop treatment guidelines. HHCPAC does not take on that role, but there are other groups at CDC that do. And this is just a couple of examples, very relevant to discussions on antimicrobial resistance, right? The sexually transmitted infections treatment guidelines, and of course, the tuberculosis treatment guidelines. When it comes to these treatment guidelines, I think CDC follows a process very similar from other groups that develop treatment guidelines. And those guidelines are based heavily on a careful review and a distillation of the studies that are done, primarily the randomized controlled trials that are done on these various treatments. Next slide. That does pose some important challenges when you're developing treatment guidelines, right? Because if you're focused only on the randomized controlled trials, it often leads you to put recommendations into a broad category, which says there's an equal level of evidence to suggest that all of these therapies are effective. The challenge is for those of you who view this from a stewardship lens, is that just because an agent has been shown to treat an infection in a randomized controlled trial, it may not mean it's the best choice from either a patient or a societal perspective. And this is just one example of that conundrum that we see. This is from the IDSA ATS community-acquired pneumonia treatment guidelines, and it says for adult inpatients with non-severe community-acquired pneumonia, here are the treatment options in no order of preference. And I added that bolding just to make this point. So it says you can use a respiratory fluoroquinolone or amsulbactam, cefotaxime, ceftriaxone, or ceftaroline, no order of preference for any of those recommendations. And that's because there's no head-to-head trials comparing these, showing the superiority of any of these agents over another. Next slide, please. And so while the evidence clearly dictates that you have to say there's no order of preference that can be made, there are, I think, a number of caveats that stewardship experts might add to some of these considerations. And stewardship folks might say, well, from our perspective, these are not all the same, right? From a societal perspective, as an antibiotic steward, is it the best choice to use an agent, a novel agent with MRSA activity to treat community-acquired pneumonia in someone who doesn't have risks for MRSA? From a hospital perspective, are quinolones the best choice if my facility has very high rates of C. diff? And from a patient perspective, again, is a quinolone the best choice if I'm at high risk for C. diff? And it leads, I think, to that question of, well, what if the guidelines came embedded with suggestions and ideas for hospitals might consider or weigh these different options to make decisions, even though there's not direct evidence that says this one's better than that one? Are there considerations that a hospital might want to weigh to say, well, in our hospital, we think this agent might be used in these circumstances? Next slide. And I think that leads us to kind of a broader discussion of ways that we could try to improve the uptake of treatment guidelines. We know one of the great frustrations for anybody who does guideline development is that, guidelines get developed, but then the implementation of those guidelines lags tremendously by many, many years. And this is not just true of infectious disease treatment guidelines, it's true of all guidelines. So can we take steps up front? Can we think about the process in ways that would improve the uptake of treatment guidelines? Could we have, for example, additional resources like clinical pathways that would guide and support the optimization of diagnoses, agent selection, and duration coming with the guidelines, suggestions on ways to assess compliance with the guideline? How would it change the way we developed a guideline if when we started at the very beginning of the guideline, we had some discussion and we were thinking about, well, how is this guideline going to be best implemented? And how might that influence the way we develop the guideline if we're thinking about implementation at the very start? We have been really pleased and privileged to be partnering and working with the Infectious Diseases Society of America to actually do just that, right? To try and develop an approach that could help the developers of guidelines think about ways that they can incorporate antibiotic stewardship principles into treatment guidelines at the very start of the guideline development process. Next slide. And I'll close just with a couple of slides about ideas that people have put forward about really changing the way that we develop treatment guidelines. Right now in the United States, most treatment guidelines are developed by professional societies, with some rare exceptions that I showed you of ones that the CDC has the lead on. There are, however, a number of other countries that have taken the approach of having a central government-funded body take the lead in writing infectious diseases treatment guidelines. And, Australia is one great example of this, but there are other countries that have done that as well. And there are some pros and cons to any approach that you would take, but people have pointed out that there are some advantages that these other countries have seen in having a central government-funded entity take over guideline development. There are the transparency that comes, the development of you can have a committee that has a broader representation, and it's not focused on one specialty or one society, and it's publicly funded, so the funding is transparent as well. And there are those who would ask, should the U.S. take this approach? Next slide. And that could certainly be done in this country, but it's important to note that if we want to go that route, this would take resources, right? And we've talked about this before. It doesn't matter what your question is. The answer is always money, right? So here's yet another example of that truism. If we want to take that route, we would really have to support this fully and thoroughly to make sure that all of these things, that the literature reviews, the administration, the logistics, the sequencing of the guidelines, when you revise them, would all have to be supported with significant resources to make sure that this process would be as robust as we want it to be. Next slide. So I'll close there and look forward to your comments and questions during the discussion period. Thank you so much.
Thank you for helping me understand the difference between a guidance and a guideline. I appreciate that. I've made some comments for the later discussion, in particular about the interplay between what you just said and the previous speaker's discussion about sectors within the agricultural community that have different levels of trust in government oversight. So I think there's some interesting things we could talk about there. So our next speaker is Benjamin Chan. with the New Hampshire Public Health Department.
Great. Good morning, and thank you very much for the invite to come and speak to this group. Again, my name is Ben Chan. I'm the state epidemiologist at the New Hampshire Department of Health and Human Services. I am also an infectious disease physician. And so my talk today is really going to focus on some of the practical experience and implications for how communications is conducted and thought about at a state public health agency. And so this is going to be really broken up into two parts. One is talking about our experience with communications during the COVID-19 pandemic, so not specific to antimicrobial resistance. And then the second piece of this is going to look at some implications for the first part on, I think, the mock scenario that you all were presented, excuse me, back in November. So before I sort of jump into talking about communications, next slide, let me just highlight the importance that communication has in, I think, all of public health work, right? As the triangle on the right illustrates, state, territorial, local, tribal, public health agencies across the country are oftentimes in the middle of coordinating and communicating experiences, events, guidance with our various regional, state, local partners, including our federal partners as well. And so the goal of any effective communication really is to have that communication be action-oriented, and the goal of that communication is to result in behavior change, right? And that's been one of the major challenges throughout the COVID-19 pandemic, is getting people to change or modify or adjust their behavior. But communication is also important because it builds trust and credibility. It's important for building these partnerships that are illustrated on the right-hand diagram. And effective communication is not a one-way street. Effective communication is a two-way street. And so good communication is important to facilitate understanding of individual and community concerns, to get that feedback loop to appropriately address concerns and issues that are being experienced by various populations. And then it's important to have effective communication for responding to misinformation and disinformation. Next slide. So let me highlight a few of my key roles in the COVID-19 pandemic response so you can understand sort of my perspective as I speak here on communication. And I think all of these roles have been important for being able to conduct communication at a state level. So as a medical provider and as a state epidemiologist, I serve in New Hampshire as a medical science and data or epidemiology subject matter expert, or SME. Review of the science and the emerging literature is important for development of guidance. And so during the pandemic, I was one of a few people that were tasked with developing public health guidance for various businesses and settings. And so actually in our state, we had a task force that was set up to draft guidance for various businesses and settings. That guidance then came to public health, oftentimes to myself, for incorporation of public health principles into that state-specific guidance that then went on to our governor's office for review and adoption. And in fact, there was a requirement under our governor's executive orders in our state for the various businesses and settings to follow that guidance. That was not a public health requirement, that was a requirement under executive order. As a medical provider, I also served as medical director for our state-run COVID-19 vaccine clinics. Heavily involved in healthcare provider and other partner communications. In fact, we were having separate webinars for long-term care facilities, for schools and childcare agencies, for healthcare providers, separate webinars on a weekly basis. There was an intense focus on public communications over the first 2 years of the pandemic. I think by best estimates, we conducted and I participated in about 120 press conferences, along with our governor and commissioner, and was providing a public health update, and then obviously frequent media interviews. And then amidst all this, there's the need to coordinate communications with our federal partners, and then also communications and guidance with state and local agencies. Next slide. Here is a diagram of some of the many challenges of communications during the pandemic. Obviously, the science was changing, and there was difficulty communicating that ever-changing science during a very rapidly moving pandemic. That science was being implemented in different ways, and so the changing guidance and the ways that the science was implemented was a challenge, right? So you had New Hampshire being compared with neighboring states, being compared with federal government guidance that posed a challenge, to explain why New Hampshire's specific guidance, that process I mentioned beforehand, why that guidance maybe differed from our neighboring states or differed from federal guidance. That was one of the huge challenges, I think, during the pandemic. That brings up issues of coordination. How does coordination happen when the federal government puts out guidance? How does that get adopted or modified by state or local public health agencies and then disseminated and communicated down to other partners within our state, within our jurisdiction? So there's a whole process of communication that has to occur. And it's not just putting information out, right? As I mentioned beforehand, communication is a two-way street. So we want feedback, which brings in principles of outreach and engagement so that we are actively engaging with people that we're trying to communicate with, not just putting information out into a black hole, so to speak. And then there is the idea and the need for evaluation. How are our communications doing? What's the adoption of guidance? Is antibiotic prescribing changing because of guidance we put out there, for example? Are mitigation measures being adopted? And that's something that, at least in New Hampshire, we struggle with. We don't have great systems for evaluation and understanding how our guidance is being adopted and whether behavior is changing. And this is something I will bring up further in the end. Next slide. I do want to talk for just a minute, though, about this relationship, I think, as you've heard from other speakers, between science, implementation of that science into guidance, and the process of communication. I've heard it asked multiple times during the pandemic, why don't people trust science anymore? Or, people don't trust science anymore. And I'm not actually convinced that it's a lack of trust in science. I think that what the public has experienced and what our partners have experienced is that different people interpret the science in different ways, and that science is then taken and implemented into guidance in different ways, which creates confusion. And then on top of that, there's a whole process of communicating the science, communicating guidance development with the goal, again, of some type of action or behavior change. And so just looking at this, trying to break out the different components, looking at the science and the data, there's a whole process of reviewing and synthesizing and interpreting the guidance and acknowledging that there are, in fact, gaps in our understanding of, in this case, a pandemic virus. There's uncertainty, and that science is ever changing. There's a need to then take that science, take the data, and develop guidance. Also acknowledging the fact that there may be local data or local contextual factors that may lead to development of different guidance between states, between jurisdictions, between what the federal government put out and what state and local public health agencies are putting out. There may be differences in guidance for target populations. There may be different laws or local laws and regulations that make one set of guidance more feasible than another. The pandemic is changing, the pandemic phases are changing, and so how the existing science is implemented may change as a pandemic progresses and as phases of the pandemic change. And then there's issues of public acceptability that we have to take into account when we're developing guidance, and a local cost-benefit analysis. So we take the science, we take the data, we review it, we synthesize it, we develop guidance, and then we have to then go through a process of communication to get that guidance, that information out to the affected populations with the end goal of behavior change. I'm going to talk more about communication process in a minute, but next slide. Before I do that, let me just acknowledge that using local data and the fact that local guidance may differ jurisdiction by jurisdiction, region by region, is not necessarily a new concept. This is a table taken from the 2019 ATS-IDSA guidelines on treatment of community-acquired pneumonia. And while we certainly don't use this term healthcare-associated pneumonia anymore, what is incorporated in this existing guidance is the concept of using local data, what they call local validation, for helping to determine antibiotic recommendations for treatment of different infections, right? So this is not related to the pandemic, certainly, but relative to antimicrobial resistance and antibiotic prescribing. It's an example of using local data and how local data may impact what guidance looks like at a state or local level. All right, next slide. So talking about the communication process, that was the arrow in the diagram 2 slides ago. This is a conceptual diagram that was actually presented by the CDC at a Science Advisory Committee meeting. The CPR, the Center for Preparedness and Response, had a board of scientific counselors meeting where they were talking about communication, and this was a slide shown by the CDC that I think aptly diagrams out the process of communication, right? Starting with the information source. That information needs to be transmitted through a certain channel, cutting through all the noise, to a receiver that then gets consumed, and then there's this feedback loop. Right. So when we think about communication, there's sort of this mechanistic process that we can think about in terms of the process of communication. Next slide. But when we think about developing communications, oftentimes we're working backwards, right? And this is a process that sometimes is called message mapping. Right, we usually start by identifying the target audience. Who is the audience that we want to reach? We need to understand that audience. We need to identify the best method or mode of communication to reach that audience. Different populations, different groups may consume information and data in different ways. So the methods of communication may differ. And then we need to give people the opportunity to communicate back to us so we can understand questions, concerns that people may have. The message content and the way that that message is delivered is going to be directly impacted by the mode of or method of communication and the audience we're trying to reach. We need to develop sort of these key communication principles and objectives, what we call the single overarching or overriding communication objectives, the SOCOs. Any message content needs to address emotions, fears, concerns, uncertainty. Some of these are basic principles of CDC's crisis and emergency risk communication. And then there's the delivery, who is going to deliver that message, the communication. Oftentimes we think of a spokesperson, but it doesn't necessarily have to be a single spokesperson. It can be an organization, but whoever's delivering that message needs to be trusted, credible, empathetic, and knowledgeable. Next slide. And for successful communication, there needs to be, as I mentioned, credibility and trust, but successful communication also leads to increased credibility and trust. So it's a circular pattern, right? Credibility and trust are necessary for successful communication. Successful communication breeds further credibility and trust in the person or the organization that's doing the communication. Next slide. So those are just some basic sort of real life thoughts and principles on how we conduct communication at a state and local level. The question I think that came up in your mock scenario would be, how would communication strategies change if there are competing public health priorities during a pandemic? So for example, a viral pandemic and at the same time, emergence of antimicrobial resistant secondary infections. Next slide. And I'll say, I think that we're dealing with the same overall communication strategies and principles, but certainly we get into issues of sort of complex and compound messaging. And so likely the way we would approach this at a state level is to try and separate out the different communication objectives by topic, right? Are we dealing with animal health? Are we dealing with human health? Are we talking about guidance for antibiotic resistance, treatment or diagnosis or pandemic virus response? Is this a healthcare setting? Are we dealing with an inpatient healthcare setting or an outpatient healthcare setting? Are we dealing with principles, the agricultural community or the general public? Is this about prevention, diagnosis, treatment? Are we talking about contingency or crisis standards of care? Each one of these different topics has different communication objectives associated with them. And once you understand or have developed the guidance, so to speak, for a specific audience, then it's, I think, a simple, it's oversimplification, a process of following the same basic communication principles. Who's the audience? How are you going to communicate with that audience? What's the message content? What are those key overriding communication objectives? How do you deliver that message from a credible source? Next slide. And so just pictorially, this is what it might look like. There's different science, different implementation guidance, different communication process involved in each one of these different aspects. Next slide. And then my final slide here is some, I think, important considerations and thoughts on communication from a state and local public health perspective. It's important to really build and maintain and leverage those federal, state, and local partnerships and communication channels. The way communication is performed at a federal level may look different from the way communication is conducted at a state or local level. State and local public health agencies are heavily engaged in trying to build up local public health infrastructure, build healthcare coalitions. Many of us have developed One Health groups that we can leverage in a scenario like you were presented, where AMR might be an emerging issue. And it's important to involve state and local public health agencies early. Again, public health structure and processes for engagement and communication are going to be different and vary by jurisdiction. We're going to have different partners, different systems for communication. And we can utilize and leverage those state and local systems for more effective communication to our audiences, the populations at a state and local level. As I mentioned earlier, state and local data, the local context and experience should ideally be used to inform the development and implementation of guidance. As shown earlier, there may be regional or local variation in antibiotic resistance rates that may impact guidance development. And then I think that, realistically, there's always going to be some translation of guidance and messaging that occurs anytime there's guidance from a federal to a state to a local level. So for all these reasons, it's important, I think, to engage state and local public health agencies early. It's also important to engage clinicians and medical and veterinary organizations early, because they're often on the front lines of addressing patient concerns, particularly related to issues around antimicrobial resistance. And then, as I mentioned at the beginning, it's important to develop, I think, evaluation systems and feedback processes, not only to assess reach of communications, but also to know whether guidance and recommendations is having an impact. And in this case, in the case of your mock scenario, one of the questions would be, is antibiotic prescribing changing? Is antibiotic use different? And so developing systems that are able to evaluate some of these processes become important. Next slide. And with that, let me end, and I'll be available for questions during the Q&A session. Thanks.
Thank you, Dr. Chan. Our next speaker is Russ Daly from South Dakota State University.
All right. Thanks for allowing me to be part of this panel. I'm Russ Daly. I'm an extension veterinarian at South Dakota State University. I also wear the hat of the state public health veterinarian in South Dakota. As I mentioned, grateful for the opportunity to be on this panel. I've already learned a lot this morning. Next slide. So I was asked to give my viewpoints on communication with various audiences, including veterinarians and the public. And that's what I've been doing for the last 17 years as extension veterinarian, and a little bit shorter time doing that for the Department of Health as state public health veterinarian. I feel like I'm still learning how to do this communication better all the time. And so my journey keeps going on even after all these years. So the bottom line up front, these are the themes I'm going to hit on, and certainly that first one we've talked about several times already this morning, the role of trust being so critical when communicating complex and contentious issues. And veterinarians as a profession that do enjoy a high level of trust with clients and the public. And we'll talk about extension veterinarians being important sources of unbiased information for those veterinarians and the public. Next slide. So I was really interested to read your scenario about the influenza that affected pigs and people with those antimicrobial use aspects. You know, and when I read through that, I listed the attributes that really stood out to me through that scenario. Rapidly evolving information voids lead to confusion and mistrust, and government authorities and experts being the early information sources. And then there's this this tug of war between what's good for the public versus what's good for my own family or my own farm. And so when you consider all of these different things, we really lived through this, through the COVID situation. And Dr. Chan brought that up very, very eloquently here earlier. And as a communicator, I personally learned some lessons through dealing with a very similar situation with COVID. I took some positions and did some communicating about some things that I didn't think were very controversial, things like getting vaccinated and not using horse medicine to treat viral infections, and it turned out to be, in some cases, they were kind of controversial among some audiences. So to me, this whole scenario that we all dealt with for the past few years has really brought up the role of trust in communication, and who are people trusting for that information on really involved subjects like this. So next slide. Because when it comes to the public and livestock producers in general, you know, they're not all driven by the same set of concerns. Every farmer is different, every producer is different, every person is different. So there's all these different things going through their minds. I think many people, when considering livestock producers and their response to antibiotic use, we immediately just go to that concept that the farmer is just wanting to make the money. You know, I don't want to lose money. I want to, you know, keep my pigs alive because that's what's going to make me the money. And in reality, all of these things are going on in individual producers' heads. And as we mentioned earlier, I could have made a little thought bubble about, is the government now going to know how many pigs I have? You know, that could be a concern for some people. And we've had to deal with some of those questions here in my jurisdiction myself. So how, as a communicator, do you know what motivates or doesn't motivate those individuals that you're trying to communicate with, and how well do you know that audience? So you, to me, you have to enlist people who do understand that maybe better than you do. Next slide. So I will submit to you that a professional who knows those clients, those livestock producers, probably better than anybody are the veterinarians, the herd level veterinarians who work with those producers on a daily basis. There's a chart there that's just one example of different surveys that have been done that elucidate the high level of trust that veterinarians have, especially with livestock producers. And this happens to be a cattle producer example here, more so than myself, state and local extension personnel. You see other producers are very high up there, and at the bottom are the government sources of information, which we've already discussed here too. But that trust that the veterinarian has with their producers is developed over time. And I really like the last speaker, how we talked about that good communication actually builds trust rather than the other way around. I think, yeah, it is something that goes back and forth in a circle. But veterinarians garnering the trust from their clients comes from understanding that operator on an everyday basis, understanding the abilities and limitations. Veterinarians are held to levels of professionalism within their practices, in respecting privacy of each individual client, you know, not going down the road and just, you know, telling everybody what this particular farm has as far as disease issues. So they're used to that. Veterinarians oftentimes will live and work in those same communities. They have experience with similar farms, and we have this education in population medicine concepts that becomes really, really important over time. So next slide. But where did the veterinarians get their information in terms of really complicated concepts like this? So in my working with veterinarians, like I say, I've been extension veterinarian for the past 17 years and was in practice myself for 15 years before that. What I've really understood, at least in my neck of the woods in the Northern Plains, is that veterinarians really trust unbiased sources. So they will look to universities with their research. They will look to extension, veterinary diagnostic labs, for example. Those are entities that aren't really trying to sell them something. They do take a lot of stock in getting information from their peers, with cattle veterinarians, with American Association of Bovine Practitioners, swine veterinarians with the American Association of Swine Veterinarians, the state veterinary medical associations, the AVMA, and they do get information from state and federal animal and human health governmental agencies as well. So it's not like they're disregarding those information sources. They do see those as unbiased sources of information. Animal health companies, they do get a lot of information from them as well, but that, in my view, is always a little taken with a little bit of a jaundiced view, because those are entities that are trying to sell them something. Next slide. There is a certain subset of the veterinary profession whose job it is to provide those veterinarians and the public with that unbiased information, and that is the role of an extension veterinarian. So extension veterinarians are veterinarians who are employed by university extension services, primarily in land-grant universities, but other places as well. Not all of them will have the title extension veterinarian, but many of them do a great deal of outreach and perform that function within their own university systems. Most of them will have practice experience, so that garners some trust with veterinarians as well, as they know where they're coming from. Most of the extension veterinarians will have advanced degrees and board certification, so they've gone on to do more specialized training. Primarily, extension veterinarians such as myself, we deal with animal health issues, so dealing with those everyday infectious disease issues and non-infectious disease issues that veterinarians need more information on to help coach their clients through bad situations. But also, and this part of being an extension veterinarian really led to my involvement as state public health veterinarian, in that we do a lot of work with zoonotic diseases and One Health issues and getting involved with public health. So extension veterinarians, that's the attributes of them on that slide. Next slide. So as part of our daily jobs, we do, our jobs are to translate these complicated concepts regarding animal and human health to our audiences. And primarily we work with veterinarians. My thought in how I communicate concepts to the public is to actually use veterinarians as kind of a train the trainer kind of issue, because they will take that information and multiply that among their clients. But we also do directly work with livestock producers, animal owners, and just the general public, oftentimes people who don't raise livestock or even own animals or own pets. We have a role, like I said, with universities, and so one of our roles is to communicate and explain research that comes from universities and translate that into real world applications. But I think what I've really been impressed with the extension veterinarians that I work with is that they maintain connections every day, every month out of the year. They are involved with the state and local producer groups, the cattlemen, the swine producers. They're involved with the veterinary professional groups. Many times they're state veterinary agencies or associations, excuse me. They have very close connections with the state veterinarians and the state public health veterinarians and state epidemiologists in some cases too. And those veterinary colleges and veterinary science departments that they work with. So just like the vets that I mentioned on that previous slide, how they are on that everyday working with those people, gaining trust. It's those relationships that extension veterinarians have with all those audiences that I think garners a little bit of trust there to begin with. Next slide. So in my job, in my job as extension veterinarian, I get evaluated on impact, right? I don't get evaluated on just how many talks I gave or how many people I reached with contacts for information. I get evaluated on impact in seeing that outcome of that information. So as a result, extension veterinarians really use a lot of different ways to get to our audiences. We have to meet the audiences where they're at. Some people will still want to open up that old-fashioned newspaper and read that article in the newspaper. Others, they don't know what a newspaper is, and they're only on their phones looking at social media. So we deal with a lot of different ways of getting those messages out there, and that's what extension people are really tasked with doing. As extension veterinarians, we do have communication infrastructure that's oftentimes already embedded in our departments and our universities, so we can use those people who are already versed in communicating and developing videos and podcasts and things like that. So we're not just dealing with one sort of communication method. Increasingly, we have to meet the audience where they're at. Next slide. A prime example of the role of extension veterinarians in explaining complicated, maybe contentious subjects was the VFD coming down the line and being implemented the first of the year in 2017. There was a lot of confusion over what this was going to mean for producers, what it was going to mean for veterinarians. People didn't understand the existing rules, so we had to start at square one. There is a lot of contention, why is the government wanting me to do this again? And so extension veterinarians were really at the forefront for educating producers and veterinarians on the new rules. Within our group, we shared a lot of information and how we were getting those messages across. I know that I counted at least 24 different talks in front of audiences and 24 different articles that were written just on the veterinary feed directive. And we were effective at doing this, or I think as effective as we could have been, because we already had that trust. We already had those relationships built. We'd already put that time into those relationships by talking to them about the boring everyday stuff, treating pink eye and mineral nutrition in their animals and things like that. We'd already had those relationships already in place. So that was, I think, really kind of greased the skids for getting those messages out on this topic that was very kind of controversial at the time and very confusing at the time. Next slide. So in summary, leveraging connections with veterinarians, I think, is a very important way to consider communicating with especially livestock producers and animal owners. Extension and extension veterinarians are some of the sources of unbiased information for those veterinarians. And I think what we've kind of talked about all morning so far is that trust underpins all that effective messaging. The messaging becomes much more clearer and actionable if that trust and those relationships are already in place. Next slide. There is my contact information. Thank you very much for your attention, and I'm looking forward to the discussion to come.
Thanks, Dr. Daly. Since I'm moderating, I want to lead off with a question. It's probably not the most important question, but it's a question I had related to extension vets, Russ, and that is, what's your impression or what do your colleagues say about the reach, the coverage, the number of extension veterinarians that are actually employed in your state, in your area, or all across the U.S., because I agree with you. There's a lot of trust. among veterinarians, with extension veterinarians and with extension in general. But I also wonder about if we are relying on those relationships, if there are adequate personnel in those positions. And, you know, you're the extension vet for the whole state of South Dakota, which maybe doesn't have a lot of people, but it's an awful lot of coverage. So could you comment a little bit on anything in that area?
Yeah, exactly. And I think we're seeing that with so many other things too, is that where are the people there to do this work? And yeah, you're right. Extension veterinarians are not growing in numbers. And for the example you gave, I'm the one extension veterinarian for the state of South Dakota. And I cover all the species, right? I cover, beef cattle and swine and companion animals and everything that kind of comes across the phone. But I would say too that within universities and land grant and extension agencies, there are a lot of people who maybe don't hold that real title, extension veterinarians, who are really involved in outreach and who do have those relationships. So it might be a little harder to find rather than just Googling or looking up on our extension veterinarian's website about who the extension vets are in a state. It might be a little harder to find those people, but there are people who are serving in those roles who maybe don't have those titles. But you're right, extension is not a growing field numbers wise. And that makes us all have to work a little smarter, I think, with some of the communication methods I mentioned to get our messages out there.
Thank you. Dr. Blazer, you're up.
Thanks so much. And I just want to start by thanking the speakers for giving such informed and provocative discussion. I have kind of a comment and a question. And I guess the first comment deals with Arjun, with your talk about, who should write guidelines. And, you're speaking as a federal official. But as you saw, the cattlemen don't necessarily trust federal officials. And unfortunately, and I say really unfortunately, there's just been such an erosion of trust in our real authorities. So we really have to have strategies that are not just reliant on governmental sources. I think that's one of the really important points, and I'd like you to comment on that. But before I finish, I also want to comment about what Dr. Chan and Dr. Daly have said, because the time to prepare for the outbreak, the time to roll out communications for the outbreak is way before the outbreak begins. It's to establish strong relationships on the ground. And I was very impressed by Dr. Daly's description of the extension veterinarian. That seems to be a perfect kind of role, deeply intercalated in the community, and builds a situation of trust so that when bad things happen, that's somebody who they can rely on. And I'm wondering, who's the veterinary extension person in human health? Who's our equivalent? I'm not sure if there are enough state epidemiologists to go around. And whether they're close enough to the front lines. The extension veterinarian is at the front line, and that's very important and useful. So with these thoughts, I'd like to open it up to the panel.
Yeah, Marty, thank you. I think it's a really valid point. I think trust is an issue across the board, when it comes to guidelines. I mean, we've seen kind of well-publicized issues in trust, even in IDSA guidelines, where there are those who have pushed back and said, this is an organization that gets a lot of money from industry. How can they develop guidelines recommending or not recommending the use of some of these drugs when the companies are providing funding for the organization? So I think that any of these processes, no matter who does it, we are going to struggle with issues of trust. And I think the issue is, as you're pointing out, what we really need to think, and I think the other panelists have all addressed this, we are really going to have to work very hard to rebuild a lot of the trust that we had in any institutions. I think the problem is not necessarily just trust in government institutions, it's trust in institutions across the board. And so we will have to work very hard to rebuild that trust. I think transparency is a huge key to that, right? So these wouldn't be government guidelines. The government would be providing the funding, but it would be external experts with clearly conveyed conflicts of interest that are brought together to produce some of these guidelines. And I think working closely on that transparency, and then as the other speakers have all talked about, learning how to communicate about what these guidelines are, how they were developed, what that process was, will be incredibly important. So I think all of those will be much needed. And certainly, like you said, pros and cons to any approach that you would take. And I think Michael had raised his hand when you commented. I don't know if he had another something to add on this from the CDC perspective. Michael?
Well, I would just add very briefly that I think, as you noted, Arjun, I think the other issue here is that the current structure is not working. And I don't think there's a full recognition that the guideline structure that we have, especially for human health and medicine, which I'll just note that that's what you were talking about primarily here. You're talking about the human health perspective here. It's not working, that we have guidelines that are not being used. We have guidelines where there are conflicts between different guidelines that societies are putting out. We have guidelines where there's not a clear indication of what the clinician should use, or guidelines that take into account stewardship or other considerations like you noted. And so it's not that we are advocating a wholesale that, we need to do it this other way, but we are bringing up that there are other approaches here, and we have to figure out how can we as a country improve our guideline development for human health, for antibiotic resistance, for antibiotic use. There are examples of guidelines where we produce them already, the STD guidelines, the TB guidelines that you mentioned, and those have, I think, some trust and uptake among the clinicians that use them, and they're seen as the ones there. The resource issue is real, and I'll just note that and underline it, is that I think one of the major issues that societies run into is they don't have the resources to be able to support the guideline development process as routinely and robustly as it needs to be supported. And that is a major challenge and a major thing that we hear all the time of why aren't the guidelines getting updated? Why aren't the new drugs that we've approved a part of the guidelines? Why aren't we taking all of these things into consideration? And that's primarily because guidelines development are working on societies that are working on volunteers. They are paid volunteers who are very busy people to begin with. There are people like of this committee who don't have the time and bandwidth to do all of these things, and we're not resourcing it as a country appropriately. And we are getting the results of that, which are suboptimal guidelines.
Jason Newland, you're up.
Thanks. Thanks to all the speakers. I want to ask Dr. Chan a question. First, I just want to thank you for all your efforts during this pandemic. I can't imagine being on that many press conferences that you mentioned. I forget the number, some 100 plus. It's unbelievable. My question is, you mentioned that you guys developed state guidances, and that would suggest, and we all know that means there's 50 states and other territories who are developing guidances. How did other states' guidances influence you all, and what is the role of the federal response? Arjun mentioned that, in helping you, and did you ever wish that we could just rely on the federal guidance?
Yeah, thank you for asking that question, and I wish I went into this a little bit more during my formal remarks. But you're absolutely right. That part of the issue with communication during the pandemic and a large part of the credibility problems both at a state and a federal level were that, everybody was coming out with their own guidance. States were being compared. Nobody knew which guidance to follow. Should I follow Vermont's guidance or New Hampshire's guidance? There are communities that live right on the border. It was just, there was a lot of confusion. And I think, so in answer to your last question, yes, I think in the ideal world, there would be federal guidance that came out that was then, adopted, with maybe minor modifications based on local situation, local context that's then adopted, and you have that sort of federal down coordination of a response like the pandemic. To be frank and to be honest, the guidance wasn't there when we needed it, particularly during the first year and a half of the pandemic, and that led to that led to the situation of states just creating their own guidance. Now, as the pandemic progressed, when you get out to the 1.5, 2-year mark, the timeliness of federal guidance got much, much better. And so one of our tactics or approaches to sort of de-escalating our response to the pandemic has been to increasingly refer to federal guidance, given that it's a couple things have happened. One is that it's incorporated more and more the state and local perspective, and two, it's become more timely. And then also, it's been less, there's been less of an urgency, and so it's allowed us to sort of take a slower pace at putting out and adopting guidance. So absolutely, yes, the goal has been, and we have increasingly just referred to CDC guidance, but that wasn't the case in the first year and a half of the pandemic, because we needed guidance. We were, being told you need to have guidance developed like in the next week, and it wouldn't come for a month, and that's just the reality of a fast-moving pandemic and the ability of a larger organization or federal organizations to respond.
Thank you. Christine?
Just had to get off of mute there. Thank you, everybody, to the team. It was really great. These kind of a group of questions are for Dr. Chan. And when we think about what we have to do to really do antibiotic resistance surveillance in a non-pandemic setting, okay, that can be really difficult, particularly thinking about is it electronically reported? Is it real time? Is it only done once a year in a hospital as an antibiogram? In 2004 in New York City, the horse was out of the barn with KPCs before anybody realized what we had. So we have all these issues. We even have issues in like huge healthcare systems where I came from, where, we would do all the hospital antibiograms, but yet as a system, we may miss something and not see it together. And then the other important area, and I think this was particular in COVID, if you live in an area where you have very high levels of resistance in the outpatient setting, do we do outpatient antibiograms? Do we know what's coming in through our EDs and in the community? So if you go back now and put that in the context of what we learned with pandemic preparedness, how can we improve on that very diverse communication between hospitals within systems, with the outpatient setting, with moving patients between institutions. All right. During COVID, you may have been admitted to one hospital, moved 3 towns over to another hospital, or you may have been placed someplace outside your normal jurisdiction. So I think all of that created a tremendous amount of difficulties in really tracking emergence of resistance that could happen during this type of a setting.
Yeah, so I think you bring up actually several different issues, and maybe I'll start and see if Arjun wants to, chime in. I think there's the question of how do you set up a system to collect antibiotic resistance data? That's sort of one question. And then the second question is how do you do that in a timely manner? And I think those are two separate problems. State public health agencies have tried to make inroads, New Hampshire included, into getting access to antibiotic resistant data. Nebraska, I don't want to speak for Nebraska, but I know that the prior former state epi in Nebraska, Tom Safranek and his crew down there had done a lot of work to make antibiotic susceptibility data electronically reportable, so that his group, and Tom Safranek is no longer, serving as state epi in Nebraska, but his group has antibiotic susceptibility data being electronically reported. I don't know in how real time that occurs, but that takes an investment in resources. Now, New Hampshire hasn't had that capability, but one thing we've done is we've made individual hospital antibiograms reportable to public health, and it's work every year trying to get that data and get that data from clinical labs in a usable, combinable format. Now, it's debatable whether you can combine, antibiograms from, hospitals across the state into one state level antibiogram, but in fact, that's what we've done. And I think that that's served a few purposes. One is to try and build up the capacity to have some type of baseline monitoring for antibiotic resistance rates in our state. Now, that's not real-time data. So in the event of a pandemic, for example, whether you get real-time feed of antibiotic resistance data, that's not the mechanism to do it. But there is that ability now to collect that type of antibiotic resistance data to try and get some kind of baseline and track resistance rates over time. And that's, in fact, what we're trying to do in the state. Setting up those types of processes also serve a second function, which is to build these types of regional, state, local groups. We formed what we call an antibiotic resistance advisory work group, the ARAW, which essentially is our state One Health group. We've brought a group of human health, veterinarian, infection preventionists, environmental health people, EMS together in an advisory work group to facilitate some of this work on collecting antibiotic resistance data. We want to try and collect antibiotic use data in a more timely manner. But this group also serves to facilitate communication and dissemination of guidance during a more emergent response. And so the question maybe has come up or will come up, well, in an emergent situation, how do you reach out to these different groups? And I think you asked that yourself, how do you reach out to the veterinarians? How do you reach out to the healthcare providers? State and local public health agencies have various mechanisms to do this, health alert communication systems, which our veterinarians are included on, by the way, in New Hampshire. We have close working relationships with our public health veterinarian, with our state veterinarian through our Department of Agriculture. We have our, One Health groups, and we would leverage all those when it comes to getting input, getting feedback, getting data, but also putting out guidance and disseminating information to various stakeholders, to various partners in the community.
And I'll just build on what Ben said. I think that very briefly, the data gap, I think, is going to improve dramatically with the new reporting requirement for the antibiotic use and resistance data into NHSN starting in 2024. It will give us required reporting from every hospital, which will include both the isolates that are obtained on admission, as well as isolates that are obtained after the patient is in the hospital. So we will have a lot more information and data from about 5,000 hospitals that will be coming in, and I think that will really help. And all of that information, of course, will be accessible to state health departments as well. So we're not just going to be the ones to see it; they'll see it at the state and local levels too. Over.
Julie.
Hi, thank you to all the panelists. This was incredibly informative. My first question, I think, is directed to Dr. Abrams, although I'd be curious what all the presenters might have to say about this. So, as I was listening to the talks, I kept thinking about McLuhan's "The medium is the message." And we heard through the different speakers about email, about podcasts, about, TV news, newspapers, of course, social media. And I'd be curious, how, when we think about federal communication, how we should be thinking about the role of the medium of the communication messages and ways in which, Dr. Abrams, you talked about designing for usability and attention, and very clearly the medium by which messages get disseminated can very much shape usability concerns, as well as, in the case of social media, have incentives to not communicate factually or truthfully. So from a communications theory perspective, I'd be very curious about how we should think about the medium element in all of this. Thank you.
Yeah, thanks, Julie. You bring up some important points. Every medium, of course, is going to have, and this intersects with what others have said as well, they're going to have specific audiences that are utilizing that medium. And so the first thing you want to understand is not only how are they using that medium, but also maybe what about that medium is dictating how that information will be communicated, how it will be perceived, whether or not it will be received, as in the case of a lot of our algorithm-driven digital media. And so conducting good audience research or using digital analytic tools that tell you things about how and what types of audiences are using those is going to be really important to understanding what are the best messages and which audiences are you going to reach through those mediums. And so, somebody who has a lot of familiarity with using those mediums might be able to anecdotally give you some initial impressions about who they might be reaching. A lot of times the free information available is just sort of the numbers that you're getting, but with more sophisticated analytical tools, or even just doing some consulting around in the literature, you can identify some pretty robust information about who is using those tools and what kinds of effects that they're having on them to ultimately understand more about your target audience.
Any other panelists want to address that question? Okay. Jay Garland.
Yes, thanks. Good morning. I got a One Health question, and we've talked about One Health, and we focused here on two legs of the triad. But I wondered, maybe from Dr. Chan's perspective, you mentioned a couple of times about relying on One Health groups. Who's your go-to trusted communicator on the environmental side of the One Health perspective?
Yeah, it's a great point. Oftentimes when we talk, particularly when we talk about AMR, we talk about human health and veterinary health, but there is an environmental component to that. I think it depends on what the question or the issue is. There's talk right now, for example, of using wastewater surveillance for tracking antibiotic resistance or antibiotic resistance mechanisms that can be detected potentially in wastewater. And that would be probably a conversation we have with our partner agency at the state level, the Department of Environmental Services. Right. So these kind of issues bring in sort of a multi-agency approach. You have Department of Health or Department of Public Health. You have Department of Agriculture coming in here, potentially bringing, a veterinary component. You have the Department of Environmental Services needing to be involved as well. And in fact, we have people from our Department of Environmental Services that have engaged in some of these topics. But you're right. The focus, at least in the past, has been more from a human and veterinary health component, and there's a need to sort of pull environmental health more into that conversation as well.
Joni Sheftel.
Hi, everybody, and thank you, presenters. You are all just fabulous. I have a question about, I want to refer back, Dr. Abrams, to what you said about porcine epidemic diarrhea virus, and I found it really it stuck with me that you said that one of the major factors in the success of the response to that was that competing narratives were quickly resolved. And, that made total sense. But then, subsequent speakers talked about how when the science changes really fast and the situation is evolving very quickly, that the narrative and the guidance has to change with it. And of course, that also varies with local and regional factors. And so then there can be alternate narratives and alternate guidances put out locally and regionally. And, to the public, this looks like there are competing narratives, even though the narrative has actually evolved, but it's just happening so quickly that unless you're in the middle of it, it looks like everyone's saying something different. And of course, that feeds the misinformation and disinformation machinery that we have really honed in the last few years. So my question for the whole panel is, what did we learn from the COVID-19 pandemic to help us address, health emergencies that are evolving so quickly that, it's an almost dizzying number of messages that are coming out that don't always align with one another? Thank you.
Dr. Abrams, do you want to address that? Joni, did you have someone in mind?
No, I didn't.
Okay.
Maybe I'll just quickly say that I think it goes back to what Dr. Daly was talking about, which is it comes down to relationships and building those relationships, well ahead of time of when they're needed.
Yeah, and I was, that work you're referring to is from Dr. Tim Selnow, and I was just kind of looking through to see if there was some additional information in that article that would allow me to quickly answer that question. Within the PEDV crisis, the competing narratives were in comparing it to another disease. Of course, I only played a veterinarian growing up. I am no longer, not one now, so I don't remember the name of that disease. And that was the competing narrative that was quickly resolved. But I see your point. It's a good one bringing forward, in that when it's so rapidly evolving, it's not just, oh, there was one competing narrative to start with, but there starts to be multiple, and your head's constantly spinning around and whipping back and forth. And so those dominant narratives emerge and become shared quickly through the relationships that and the collaborative networks that Dr. Chan just referred to, which helps expedite what needs to be a dominant narrative going forward.
Yeah, Joni, I don't have a good answer for that, as I usually don't have good answers for your questions. But I think we referred to it earlier, is that sometimes I wonder if part of our messaging being how we got to the message. Okay, here's the process. Here's the evidence that we use to get to the message, and having people understand that might help them understand when that guidance has to change, because of, okay, we now have different information. Remember, we told you this is the information we use. We based our recommendation on this piece of information. Now there's a different piece of information. So maybe part of it is being more open and transparent about how we're getting to our recommendations, if that's possible.
So a little bit like if we're creating clinical guidance or clinical guidelines, we are very transparent about how the evidence was evaluated, who did it, what all of those things, right? Elaine.
Yes, I want to go back again to Dr. Srinivasan's comments about guidelines. And it seems to me that, even before we had the misinformation and the trust problems, this country is sort of negatively, they perceive any guidance as negative. It has to do maybe with the independent nature of our culture or whatever, don't let anybody touch my Medicare, that sort of thing. But years ago, probably about a decade ago, the Agency for Healthcare Quality and Research did go into the business of guideline development for about a decade. And I love the guidelines. There was a guideline, national guideline database, all this stuff. But they went out of that business. I think part of it was because there were special interest groups that were really pressuring them. But it might be helpful to understand some of the lack of acceptance of guidelines, to sort of look at what happened there. I don't know all the things that happened, but besides the difficulty of writing them and keeping them updated, I think there's a cultural issue that maybe some history about what happened with AHRQ that we might learn from. Thank you.
Yeah, it's a great question, Elaine. I don't know what happened with that experience. I mean, I know AHRQ continues to host the U.S. Preventative Services Task Force, which is, in a sense, a guideline body. They are making formal recommendations, which are then, kind of taken up by insurance companies and other payers. So they do continue to have that experience. But yeah, we can definitely inquire with them. And Melissa Miller's on the call. She may know more about other types of treatment guidelines that they might have been doing that they got out of the business of, and why.
Well, thank you. But they actually wrote a series of guidelines, at least 10, and then they had a national guideline clearinghouse where they vetted guidelines from other groups, and that's
Right.
gone as well.
I think Melissa is raising her hand to respond.
Yeah, go ahead.
Yes, yeah. So, Elaine, I apologize. I've been with ARC 7 years. You may know a little bit more about the 10 guidelines that were written, but it's my understanding that, we have two separate arms here. One was the, USPSTF that Arjun mentioned, and they continue their work. There was some controversy a few years ago, and occasionally when they come up with recommendations, and that is a separate issue. The Guideline Clearinghouse was maintained for many years, and I know much beloved. The money ran out for that. And so, but that was not, those guidelines were not manufactured or created by ARC. They were simply hosted. Maybe you can tell us a little bit more about the 10 guidelines that were created, but, they're different arms here of function.
Well, it would have been nice to maintain the National Guideline Clearinghouse because they vetted guidelines from a variety of organizations and so forth, and that kind of assured that they had been reviewed just outside the organization. And the guideline development preceded the National Guideline Clearinghouse.
Mm-hmm. I will share your dismay at the loss of the hosting ability, as do I think many clinicians, but that was a function of budget.
Dr. Plummer, Paul?
Yes, thank you, and appreciate everybody's presentations, informative, and looking forward to more on this topic after lunch here this morning. But one question I wanted to ask the panel, and may ask again this afternoon to the panel this afternoon, one of the issues that I kind of routinely struggle with is particularly early on, for instance, in the pandemic or in really any sort of communication challenge that we're focused with in rapidly changing information. You don't have research to begin with at the beginning, and so you're making kind of best educated guess type of decisions. What have you all found is the best way to present uncertainty in the message or known uncertainty in the recommendations, while at the same time invoking credibility and confidence that you're not just kind of pulling this out of a hat and completely guessing? And so would be interested in anybody's comments on that. And certainly as a pandemic or anything proceeds, I think our level to make recommendations increases and our uncertainty decreases, at least in some areas. But how's the best way to do that in messaging where you don't lose people because your message changes a couple of months later and you knew it might change, but you didn't want to just kind of sound wishy-washy at the beginning?
Yeah, but Paul, I think that's a great question. And it's a point I think where I think all of us who did this didn't do as good a job as we could have done. I think we learned. I think we got a little bit better, but I think we're still a long ways from where we'd like to be. I think what you have to do is continually convey that the recommendations that you're making are based on the data that you have right now. And part of that is being transparent about the information that you have right now. CDC did move towards putting what we call the science briefs up on the web so that everybody could see, look, this is the body of evidence upon which we're making our recommendation. And I think sometimes, we need to be more transparent about including all of the factors that weighed into a decision. Because sometimes the decision is not just based on the evidence, it's based on the practicalities, right? A recommendation of what masks that you might use might somewhat depend on the availability of the masks that are there. And I think you have to be transparent about that. And I don't think we did as good a job as we could do in some of that. I think if to me, I've encouraged people here to really look at what CMS does when they do their rule writing process, where when they respond to comments, they will say, we reviewed the comments that said this and reviewed the comments that said that. And, on balance, we think that we're going to take this approach for these following reasons. And I think we probably need to do much, much more of that. The challenge is, the people already say your guidelines are too long, and adding all of this in makes the guidelines even longer. so maybe it goes somewhere else. But I think the more that we can share with people the process that went into the recommendation, it at least allows them to say, I don't agree with that recommendation. I don't like that recommendation, but now I see why and how they got where they got.
Yeah, if I can also chime in and say, I think those science briefs that Arjun brings up were actually a really helpful communication tool, particularly for state and local public health agencies, then taking those recommendations and disseminating them. And I would say that even at a state and local level, we were doing something similar. We were having weekly calls with different partners, long-term care facilities, schools, healthcare providers, and we were presenting and talking about the data. Here's the recommendation. Here is why there is that recommendation. Here's the science behind it. And so the science briefs that CDC developed were really helpful in that regard. But I think it also brings up the issue of, it's not, when we talk about effective communication, it's not just putting guidance out there. Here's the guidance, go and do, right? There's a whole process of engaging people. And that's why I try to separate out the process of communication from, engagement and coordination, because it's not just putting information out there. It's not just putting the guidance out there. We need to, have a discussion with whatever population we're trying to communicate with about the guidance, why the guidance is that way, and provide opportunity for feedback to answer questions and concerns that people may have. Now, I want to bring up another issue that's not what you're asking, but I think it's a related topic that I've noticed. And there's always this balance between putting out timely, accurate, reliable information and putting out information that the community wants to know. And one of those things that keep getting asked over and over again is, what's going to happen during the summer? What's going to happen during the winter? What's going to happen in the future? And what I've experienced is a real hesitancy for public health in general to engage in that question. And the stance is always, well, we can never predict what a pandemic looks like, or we can't predict what a flu season is going to look like, or we're not going to predict or make any comment about what's going to happen during the summer because we don't really know. And that's a true and accurate statement, but it doesn't actually answer the question or address the need that's out there for some information. And so what I found is that there's actually this balance between expressing that uncertainty, providing accurate, up-to-date information, and doing some type of forecasting or predicting of what we think might come based on our experience in the past and based on the science that we have at our disposal at the time. And so we've tried to do this at a, just speaking from my own state perspective, we tried to do this with the issue of COVID-19 vaccination, right? There was a lot of discussion this past fall about sort of how it's a surprise and, how vaccines are rolling out and boosters are being recommended. But honestly, if you look back at, we were talking about the need likely for a booster dose back in March of 2022. And so, there's always this opportunity, I think, to get communication out there, messaging, forecasting or predicting or whatever you want to call it. But frame that in the context of here's what we think is likely going to happen based on the science and our experience now. But that's always open to change. And I think we actually need to do more of that type of messaging, more of that sort of near term, near future forecasting or predicting based on the information we have at hand, acknowledging that could be wrong. We don't always know, but based on our best knowledge, the best science, here's what we think is likely going to happen, over the summer or over the winter. Obviously, the further out you get, the more difficult that becomes. But there are some aspects of this which I think can really help uptake of guidance, uptake of of messaging and communications.
Russ or Katie, do you have any comments on this communication of uncertainty? Because to me, it's the crux of a lot of these conversations.
Yeah, just to add on to what the other two just said, mentioning what additional data are in process as well, doing some of that forecasting. I noticed throughout the pandemic, just in my own media consumption and sort of reflecting on that as a scholar as well, that you would see a lot of course, journalists who are dedicated to covering a particular issue, who are a part of those collaborative networks that we've all been talking about as being important to trust and relationship building. And they were some of the key people out there who were doing some of that forecasting and communicating it to a wide audience based on the conversations that they had been having and the reporting that they had been doing and investigating that they had been doing as well. So we don't want to overlook the importance of those journalists. And when, of course, just in connecting back to my own work within the agricultural sector, those journalists for those major media outlets like the cattlemen journalists who are trusted, and maybe when guidelines come from them, understanding how they were developed, more likely to be paid attention to when coming from those more trusted media sources compared to just the government sources themselves. Another thing to point out here too is that in a crisis, when there's sort of this finger pointing of you said this at this time, why is the story changed now? Well, sometimes that's said because you all are probably well aware of this. Not everybody has an interest in resolving a crisis. And so they, of course, use sort of what they thought to be a sure recommendation. And then when you change your recommendations to attack someone's or an organization's credibility because their motives are, they have a different agenda and they're using that as a platform to advance that agenda. And so I think pointing out that, maybe you have information about the uncertainty or future data that's going to be collected, forecasting, things like that, that help people be a little bit more flexible to future changes. Maybe that's not embedded right there within the guidelines, but it is not too far away, very easy to find.
Locke.
Well, I want to thank the panelists for the information. I found it really useful. And just one comment and one question. With respect to the PED example, one thing I think might be important in terms of perspective, especially for my friends and colleagues on the human side. I mean, the communication challenge is orders of magnitude smaller, and there are fewer than 1,000 veterinarians who probably saw a case of PED or were involved in making health decisions for a group of pigs. There are a lot of pigs, but there are very few decision makers. And there's also orders of magnitude fewer people who are watching those messages and interpreting them and using them to make points outside of the objectives of getting the right health information across. So it's a way different environment in that respect. And maybe the lesson there is that some sort of compartmentalization or those local trust structures are really critical in reducing the breadth of sources and the number of people in the discussion. The question I have maybe for Dr. Abrams or Dr. Daly, in your research you're aware of, did you find evidence of what motivates groups or people to prepare the messaging ahead of time? For example, I think currently we're reasonably well prepared for African swine fever on the messaging side, but it's a catastrophic potentiality. The question is, how do we motivate the effort up front for things that have a less catastrophic negative outcome?
So I don't, and I worked closely on this work with USDA APHIS, the NOMS unit specifically. So I'm speaking from a somewhat limited perspective there. In working with them, they really benefited from a lot of help around communication capacity building and science communication capacity building. And so that was something that we were working with them on to get them, all the different veterinarians and personnel that work both collaboratively with NOMS and APHIS, as well as those that work within APHIS, to be thinking about communication implications of the various diseases on the forefront, the animal health issues that could be coming. And so by developing their capacity for communication a little bit more, it could be one way to help them be more comfortable and anticipating that space that they'll need to be in, developing messages for those less catastrophic things that evoke that less fear and emotional response in them, if they are have a little bit more capacity for science communication, to be thinking that as a part of their role as well.
Yeah, that's a really important question, Locke, and I don't know that I really have a good a feel for that, but it does come down to at least having some understanding of what is actually important to individual people, and individual producers. And I don't know how you get to that, but it might just be part of the hard work that has to go into the two-way communication. Is if we have ASF happen, what for your farm is going to be most important for you? Is it going to be the economics? Is it going to be the social aspects of you being the farm that has it and nobody else has it? What are you worried about? And they might not know that until it happens, right? So it's hard, and it might mean just more hard work. But I think the more we can understand what motivates individual people, I think we might be surprised to hear what some of those motivations are.
Thank you.
So last couple of questions. I think, Stephanie, you're next.
Yeah, hi. Thanks again to the panelists for great talks. I guess one sort of a comment and then a question. The way my comment is framed is around guidance, which is for more sort of acute issues and changing situations, and the other more on guidelines. And I do want to emphasize how much on a local public health level, it was so important. CDC would come on calls with state epidemiologists as things evolved and when communication got better, to talk about guidance that was going to be coming out. And I thought that was extremely helpful. And then on a local level, that we engaged hospital epidemiologists, who were our kind of, I think, analogy to the veterinarian outreach, the extenders. It was critical for us to review guidance that was coming up with our hospital EPIs to get their feedback. And then also having a dashboard, having better metrics and dashboards was really essential on a local level for people to know what was going on. And so I'm really excited to hear on an AMR topic, and then more on kind of the guideline, kind of the long-term nature of AMR, that, NHSN data will be becoming more available with requirements in 2024. But I'm interested in the Center for Forecasting and Outbreak Analytics, and if there are plans to cover AMR in that, and just to emphasize again how helpful dashboards have been in terms of engaging stakeholders and being a route of communication. So I was directed at Arjun.
Yeah, we have quite a modeling team now in our division that is focused on a variety of things. They've been doing a lot of COVID modeling, but their bread and butter is AMR modeling, right? All the early CRE modeling, all of that work came out of that group, and that group has very, very strong connections to the Center for Forecasting and Analytics. So I think you will continue to see growing use of modeling in AMR work. CDC we have a expert group called the Mind Collaborative. So we now have a funded external group of modeling experts who are focused on infectious diseases modeling, particularly AMR focused modeling. So I think there's a lot of good work that has come out of that group and that will continue to come out of that group.
All right,
And
last question.
If I can.
Oh, sorry.
I'm sorry. I was just going to echo what Dr. Black said, which is that, and in response to an earlier question around, state and local public health agencies adopting CDC guidance, and I think one of the processes that has really facilitated that, and our ability to sort of take federal guidance and understand it and disseminate it further at a state and local level, really is the increasing engagement and the work that CDC has done to reach out to state and local public health agencies, leadership, through ASTO, through CSTE, through the state epi groups, to really ahead of time. Again, the emphasis here being before, something happens, before something's released, engage state and local public health agencies and share the guidance, even if it's a draft version, share the reasoning, the science behind that guidance, have a discussion so that state and local public health agencies are then equipped to be able to, know when that guidance is coming out and be able to take it and run with it at a state and local level. So thank you.
All right, last quick question, Dennis.
And just a comment to thank all the speakers on this very important topic of communication. And even in speaking on research from NIH, I've taken to closing my presentations with my thoughts that three of the most important points in resistance are communication, communication, and communication. And we can only do what we can do. And we know that that vast variable of human behavior really complicates all of this, because if you think of human health and maybe take something outside of infectious disease that's critical to your survival and your well-being, the willingness and ability of people to do what they know they need to do in their own best interests, very, very complicated. And thank you for sharing your knowledge about how to communicate.
Thank you. Back to you, Joanna.
Thank you, Virginia, and thank you to all of our presenters today and for this great discussion. I love that we continue all to the last minute. Folks, we're going to break for lunch right now, but we hope you can join us back promptly at 1:10 for a 1:15 start for the live stream, and we'll continue this conversation on communication at that point, and the Q&A will also ensue after the panels. Thank you all so much, and we're going to break.
Produced by the U.S. Department of Health and Human Services.